Good morning, everyone. This is Eric Ankerud. I am the CEO, president of Heartfelt Dreams Foundation and a co-founder of this nonprofit charitable organization dedicated to providing emotional, educational, and financial assistance to congenital heart defect patients, their families, and the doctors and nurses who care for these patients. I'm very pleased to start this virtual cardiac nursing seminar with an illustrious team of presenters from the Massachusetts General Hospital Heart Center and the Adult Congenital Heart Disease Program. Special thanks to all the presenters for this morning's program, and a special thanks to Sharon Gallagher and Lauren McLaughlin for their championing and dedication to making this seminar happen. This session will be recorded so that we can provide this information and educational material to others who will not be able to participate live on the seminar this morning. And we're also pleased that we will be able to provide continuing educational units for those who do participate. We have a participation list from nurses and nursing students from across the country. And we're very pleased at Heartfelt Dreams Foundation to be working in collaboration with the doctors and nurses at Mass General. And with that, I'd like to introduce Dr. Doreen DeFaria-Yeh, a medical advisor to Heartfelt Dreams Foundation and a good friend. And we welcome Dr. DeFaria to introduce the session.
Terrific. Well, thank you so much, Eric, for all that you have done and all that Heartfelt Dreams has done to support our congenital heart patients in their medical care, the emotional support that you have provided, and importantly, all that you've done to support education in the field of congenital heart disease, particularly as it pertains to management of adult patients. I will share that the Heartfelt Dreams Foundation has been absolutely transformative in the care for many of our patients, and many of our patients have turned to you and your foundation for help and support in getting to Boston for specialized procedures that they need for their unique heart and their unique heart anatomy. So I want to thank you again for all that you have done to really help us all be better educated about how we can help and support our patients. A wonderful morning of talks that are scheduled today. I want to recognize our two nurses extraordinaire in our congenital heart disease program here at Mass General, Lauren McLaughlin, who is an RN and really a central linchpin in our program, helping to manage our patients, their calls, their medications, the questions that come up, and being a terrific source of support for our patients. And Sharon Gallagher, who is a nurse practitioner with so many years of experience in cardiology and congenital heart disease, who sees patients with us side by side to support their care and ensure patients have touch points to ensure all their questions are answered and conditions are managed. We could not take great care of our patients without the two of them, and they put a tremendous amount of energy into the program today. So thank you both so much for all the work that you've done. This morning, you'll hear about a number of different topics in the field of congenital heart disease. This by no means covers all of the different topics that and different disease conditions that we see come through our adult congenital heart disease clinic, but some of the more common congenital conditions from our perspective. Certainly, congenital heart disease is a team sport. We cannot take great care of patients without a whole team of providers, practitioners, nurses, technicians, both in the outpatient setting and the inpatient setting, who really understand some of the ins and outs that are unique to congenital heart disease. So today, a few of the congenital heart defects we'll be talking about include atrial septal defects and ventricular septal defects by Dr. Chris Learn, another one of the adult congenital heart cardiologists in our program, coarctation of the aorta, another fairly common condition in our clinic by Dr. Ami Bhatt. I'll talk a little bit about tetralogy of Fallot. Dr. Ada Stefanescu will talk about catheter-based innovations and interventions for our congenital heart patients. Sharon Gallagher will spend some time talking about an area she is very expert in and passionate about, exercise and safe exercise in the congenital heart patient. And then Lauren will wrap up with some important concepts in managing outpatient issues that arise for our congenital heart patients and how to do that as seamlessly as possible. We'll wrap up the morning with a question and answer session. So as you have questions, please feel free to feed those through the chat function. We can collect those and make sure we address them at the end of the session. And of course, hope to hear your live questions that come towards the end. And it's wonderful that this content will be available on demand for later review for those who could not make it with us today. So it's such a pleasure to kick things off and introduce Dr. Chris Learn. Dr. Learn is the upcoming director of our adult congenital heart disease program. He is board certified in probably every specialty that you can imagine: adult medicine, pediatric medicine, adult cardiology, pediatric cardiology, and adult congenital heart disease. So he is extraordinarily experienced and trained in managing the unique conditions that our ACHD patients see. And he's also a terrific teacher, winning some teaching awards from our fellows last year for clinical excellence in teaching. So thank you so much, Chris, for starting off our day, and I'll turn it over to you.
Thanks very much, and thanks for setting the bar so high. So, but now we'll get started here. And I will say, I really would want either in the chat or periodically we'll sort of open it up if people have questions, because I think whether when you're speaking to medical professionals, there can be a wide range of people's experience and comfort levels with things. And so I'll try to aim at a level that I hope will address most people. I'm sure it'll be more basic than some of you, may already know a lot of this stuff. And if I slip into things that are, congenital heart disease lingo, if you're not familiar with it, feel free to say something and I can try to clarify. So I'm going to share my screen here. Actually, I'm getting an error. It says host disabled screen sharing. Is there a, I don't know if there's a way I can, okay, it looks like now it's giving me the option. Okay. All right, can you guys see the first slide okay?
Yes, we can.
Okay. And I'll try to stay on time as well. I can sometimes blather on a little bit, but just let me know if I'm running late. So, okay, so atrial and ventricular septal defects. Okay, so we'll start with atrial septal defects first. So I'm going to use this little video which shows how the atrial septum forms. So this is an early heart that you would see. It's a cartoon of what you'd see in a fetus. And this is kind of looking at it from the right side of the heart. So we'd see the right atrium in the foreground and the right ventricle in the towards the right of the screen. And if they kind of cut it open so that you can see the interior of the heart, you could actually see deep into the left atrium and the right and left ventricles here. And the atria and the ventricles, the upper and lower chambers, kind of split off from each other. First, there are these ridges of tissue that kind of grow in from the center part of the heart. These are called the endocardial cushions, and they help partition off the atria from the ventricles. So they kind of both pinch off left and right, and they also kind of pinch off up and down to help separate the atria from the ventricles. And then there are these ridges of tissue towards the exterior of the heart, which will then grow inward. So the ventricular septum will kind of grow in, separating the right and left ventricles. And then this animation doesn't show, but there's another ridge of tissue that comes down from the top to kind of meet those. And then the atrial septum, the first part of the atrial septum, the septum primum, will kind of grow from the outside in. And just as it starts to seal off completely, these little holes start to develop in the upper part of that septum, so that nature sort of creates a second hole here. And then the initial septum, the primum septum, will close off completely here at the center part of the heart. And then a second ridge of tissue called septum secundum, again, doctors love Latin, so it's the second septum, will come in and kind of grow from the top down and create a flap over that second hole that developed later on. And this creates the foramen ovale, or eventually it'll be kind of an oval dimple here called the fossa ovalis But this kind of creates a little flap-like opening between the atria and the ventricle. You might ask, like, why would it form that way? What advantage does that confer? And so this is showing the fetal circulation. So you and I as adults, or even as infants, we get all our oxygen breathing on our own from our lungs, but the fetus gets the oxygen from mom via the placenta. So the placenta brings this oxygen-rich blood in through the umbilical vein into the inferior vena cava, and that directs blood towards the atrial septum. And having a little communication here allows some of this really oxygen-rich blood to more easily get to the left side of the heart, and from there get to the brain. So this is helpful in fetal development to have a little flap here so that oxygen can get to the head. And but this process of these septums forming can have problems at different stages of development, and that can lead to problems in different parts in the atrial septum where there can still be communications between the left and the right side of the heart. Down here towards the kind of the center of the heart where the atria and the ventricles meet, if there's a hole here where the primum septum didn't finish forming completely, that's a primum ASD. In the center part of the heart, which are the most common, or the center part of the atrial septum, the most common type are these secundum atrial septal defects. And then along the back wall of the heart, where the veins that come back from the lungs, the pulmonary veins run, this would be where sinus venosus atrial septal defects can occur. So just another way of kind of showing this again, where we have these kind of two different septums that form. The first one being the red septum here, if we look at it from the front view on the right side of the images, or from the right atrial side, the red is kind of that first septum that forms, and then the teal is kind of showing the second septum. So normally they should kind of overlap, and there's a little flap-like pathway for blood to flow through, but there's not exactly a singular hole through here. The most common type here in the center part of the septum, that there's a little gap here where blood can go from the left atrium to the right atrium. The next most common type is the primum defects, where again, towards the center part of the heart where the mitral and tricuspid valves are, just above the ventricles, there can be a hole down here because the primum septum doesn't form normally. And then in the back, kind of the back wall of the heart, up in the very top part of the heart, this is where the sinus venosus defects could occur. So what does this do? Well, one of the ways to try to help talk about this is to talk about the blood flow in the different chambers of the heart. So this is a box diagram. The numbers on the inside are showing the levels of the oxygen here on the right side of the heart. So we've got the inferior and superior vena cava bring blood back in from the rest of the body to the right atrium, to the right ventricle, the pumping chamber, and now out to the lung arteries, the pulmonary arteries. Blood goes off to the lung, picks up oxygen, and comes back through pulmonary veins to the left atrium, left ventricle, and then from there it gets pumped out to the body through the aorta. The pressures here are, here's the mean pressure. The average pressure in the right atrium is about 3 and the left atrium is about 8. So low pressure in both atriums, but a little bit higher on the left atrial side. And then in the right ventricle, systolic pressure around 25, whereas the left ventricle is usually 100 or more. So much higher pressure in systole in the pumping chambers. So if you have a gap in the atrial septum, you've got the normal amount of blood flow coming back from the rest of the body coming into the right atrium. And then you've got this other blood coming over through this hole. So you have more blood flow coming into the right atrium, across the tricuspid valve, through the right ventricle, the pulmonary arteries, the pulmonary veins, then into the left atrium. But then it sort of balances out here where some of that blood, it's already picked up oxygen, goes through the hole and takes another trip around the lungs. And then a typical normal amount of blood will still go through the left atrium and left ventricle and out to the body. So over time, that'll enlarge the right atrium, the right ventricle, and the pulmonary vasculature. And if we were to try to measure the amount of blood flow, either with a catheterization or an MRI, we'd see in this example, there's about twice as much blood flow to the lungs, or what's called QP or pulmonary blood flow, versus the amount of blood flow that's going to the body of the systemic circulation, or QS is often abbreviated. So over time, having a big ASD or a medium ASD can lead to enlargement of the right atrium and the right ventricle. The pulmonary valve and the pulmonary tricuspid valve can stretch out, and the lung artery and veins can stretch out. And there's an increased risk of atrial arrhythmias. And in some patients, this excess blood flow can cause the lung arteries to stiffen over time. This is a graph from the Mayo Clinic just showing like how we tend to find these. If we look at the secundum defects, they're here on this, basically the green bars are saying that you pretty much should be able to see any of these from a transesophageal echocardiogram. From a regular transthoracic outside looking in echo, If they're small defects, like less than 5 millimeters in size in an adult, you may only see them about a third of the time. Whereas if they're over a centimeter in size, they really should be able to be seen easily on a transthoracic echo. The primum defects that are in the center of the heart, really you should be able to see. Those are very distinctive and they're usually easy to see. They should be able to be seen either in regular transthoracic echo or TE. But the sinus venosus type, because they're hard to visualize, they may only be picked up on a regular echo about 9% of the time, where you should be able to see them in any thorough TEE. And I just bring this up is because the sinus venosus type is one of the type that might present later in life. It might have evaded detection and only be found later on in life when somebody does a CT scan or has a really high index of suspicion. But just talking again about the most common type here, we've got the secundum atrial septal defect, and this again from the right atrium and the right ventricle view, and here's the hole right here in the center of the right atrium. If a child is born with an ASD and there's nothing else going on, they're typically going to be very well as young children, unless the hole is absolutely massive, because the heart can usually tolerate, the lung can tolerate a little bit of excess blood flow. Small atrial septal defects can close spontaneously in kids. Sometimes they remain stable in size. It's less common if they'll enlarge. But if you've got a kid that's got a defect that's more than 6 to 8 millimeters in size, or if it hasn't closed by 2 years of age, it's unlikely that it's going to close on its own. If it's big enough to be causing changes in the right side of the heart, then we usually would recommend closing one of these. And the outcomes are better before age 25. The outcomes are not horrible after 25. But when you think about the risk of long-term heart rhythm problems like atrial fibrillation, or the risks of things like changes in the pulmonary blood vessels, those are more likely to be persistent if it's caught later in life or repaired later in life. Sometimes the atrial septum does not just have one hole, sometimes it's got a little pattern of multiple holes, and that can present a closure. This is showing the right atrium from the right atrium side, superior vena cava, inferior vena cava, and this kind of multiple little fenestrated holes in the atrial septum. So sometimes that can present a challenge when we try to close them in the cath lab with a closure device. This is showing an echocardiogram. This is showing the 4 chambers of the heart, the right atrium and right ventricle on the left side of the screen, and the left ventricle and left atrium on the right side of the screen. And here between the 2 atria, you can see this kind of blue-red jet. Normally, this should be a solid sheet of tissue and there shouldn't be any blood flow between the two, but this is certainly a bigger ASD, and we're seeing blood flow going from this slightly higher pressure left atrium into the right atrium. Okay. Oops, hold on a second. This is, we often use agitated saline, so kind of putting a little bit of air, salt water in a saltwater solution to kind of try to pick up on small defects. That's not really necessary in this patient. You can see that there's a left ventricle on this side. The patient's got a larger than normal right ventricle, but this patient got contrast anyway. And what you can see is the bubbles come into the right side of the heart here in a second. You can see this little black jet. This is blood flow from the left atrium, kind of pushing those bubbles out of the way. And that's the way that blood flows most of the time, is that most of the blood from the left atrium pushes into the right atrium. If people burp or hiccup or have a Valsalva maneuver, like with a bowel movement, that might shift, having some of the bubbles go in the opposite direction, but most of the time the flow goes in the other direction. So, in the modern era, most of these, unless they're really, really large, can be closed with a catheter procedure. If they're very, very small, they may not need to be closed, but if they've caught, again, if they're changing the right side of the heart or causing other problems, we usually would recommend closing them. This is an earlier device where it was sort of a cloth on kind of like a double-ended umbrella. This here is an Amplatzer device, which is a more modern device. It's got a flexible nickel titanium mesh or nitinol mesh, and then fabric in between. And then this is showing a Gore septal occluder helix device. It's got a rim of kind of flexible metal on the outside and then fabric in between. It's designed to help have a better job of closing some of those defects that have multiple little holes. And this is showing from how basically it works in the catheterization is that a doctor will put a catheter across the hole and then push through the device one half of the closure device, and then they'll kind of pull the whole thing back to snug it up against the septum, and they'll push out the other half of the device to sort of sandwich both sides of it, and that will sort of plug off the hole, and then the devices can be released either by unscrewing or sort of pulling a mechanism, and so that the device is left behind. It sort of helps close off the left atrium from the right atrium, and eventually the lining of the heart should grow over that and seal off the defect. To do this, there have to be good rims of tissues. There's different ways, different authors have described these rims of tissue, but basically you got to make sure there's enough for the device to grab onto, and that it's not going to end up pushing on an adjacent structure like the tricuspid valve or the aortic valve. Sometimes if there's one of these rims is very small and it would not hold the device well, or the device might end up rubbing up against another tissue, that may be a reason that we would still have to recommend the patient having open heart surgery to repair the defect. And this is just showing kind of 3D echo pictures of how these devices are kind of deployed through the atrial septum, and kind of one half is pushed through and then snugged up, and then so that over time they should hopefully grow over this. Switching gears just a second to talk about primum ASDs, where that's more towards the center part of the heart. This happens because usually at a very early stage in development, so the heart actually starts off as a tube, which sort of, again, those endocardial cushions sort of pinch off the right and left sides of the heart and separate them from each other. But if that doesn't happen correctly, that will affect how the walls between the heart form, as well as how the valves of the heart. So this is showing very on in development. This will eventually become, this is the left side of the heart, and this is the right side of the heart. And these ridges of tissue eventually become the valves. And usually what happens, and this line here is the ventricular septum that separates the two pumping chambers, is that over time that these leaflets tend to fuse, and so that after birth you end up with one big leaflet that started off as two leaflets here for the anterior mitral valve, and then this leaflet turns into the posterior valve leaflet. And the same thing happens on the tricuspid valve side, is that some of these leaflets fuse together so that you end up with 3 cusps instead of 4. Well, in these patients who have these sort of primum defects, they're also in a family of defects called atrioventricular septal defects. So they often involve both an atria and a ventricular hole, or sometimes they're called AV canal defects. And often the mitral valve often has this kind of notch in it or we call it cleft, where it doesn't seem to close as well. Some patients just have the atrial septal defect. Some patients have more of a tiny ventricular septal defect. Some people have a big VSD. Sometimes the heart stops developing correctly very early on, and there's, instead of being 2 separate valves, there's one big valve that spans both sides of the heart. And this is showing an echocardiogram picture. This is the left atrium, the right atrium, and the left ventricle and the right ventricle. And here's this gap right down here at the very center of the heart, right above the tricuspid and mitral valves. And this is showing a zoomed in picture showing it right here in the center of the heart, that little bit of blood flow going between the two. In this view, the atria at the bottom of the screen, but they're flowing over from here, right at the center of the heart, right between above the heart valves. And just to show a little bit again how that mitral valve is often affected, this is showing a normal mitral valve that's got a big anterior leaflet and a smaller posterior leaflet. There's just kind of 2 leaflets of that. And this is showing again kind of how that would look normally. And then if this doesn't form correctly, there's often this kind of notch here. This should be a separate valve, but here's one big valve that's sort of separating, and there's this cleft here. And the surgeons may repair the hole and try to separate the 2 valves, but often there's still an indentation here that can cause regurgitation as people get older. And this is showing an echocardiogram. This is showing the heart, looking at it from kind of the side or the short axis view. This is the left ventricle here. This is the right ventricle here. Normally that mitral valve is a single continuous line here. And then this patient here, this one's got a cleft. So whereas here, this is a single line, we can see this gap here in the anterior leaflet of the mitral valve. And that often leads to regurgitation later on in life. And that often is the most common reason for these patients to need a repeat operation later on in life. And just to be clear, these defects, because they run so close to the valves, they can't be closed with our current catheter technology, because the devices would end up interfering with the valve function. And so these have to be closed surgically. And then finally, the last type of ASD is the sinus venosus, which is kind of really like less so in the main part of the atrial septum and more often in the back wall of the heart. Again, this is an echo view, again, showing that these are hard to see. This is the right atrium and the left atrium, and these are hard to see in this view. Sometimes, if we're lucky, this is looking at it from the liver, the subcostal view, where the liver here in the top of the picture. Here's the inferior vena cava, bringing blood from the lower half of the body, and this is the atrial septum. And this should continue as a straight line all the way over here. And this is the superior vena cava, bringing blood from the upper half of the body. But there's this big gap here, which allows blood flow from the left atrium to come into the right atrium, and there's a vein here that from the lungs that should be connecting to the left atrium, but instead is sort of straddling this area. And again, this is showing an anomalous pulmonary vein. So this is a vein from the lungs that instead of connecting, it's connecting to the SVC. This is what we might see on an echocardiogram. This is showing color. This is showing blood flow going through that gap, connecting the left atrium and the right atrium. But these, again, this is showing a CT picture. This is showing the superior vena cava, bringing blood from the upper half of the body. And these are veins from the lungs, which should eventually end up over here on the left atrium, but they're instead connecting abnormally to the superior vena cava. This often, again, these abnormal connections have to be corrected surgically. There are some people who have worked out a transcatheter way of doing it, but I don't say it's experimental, but it's relatively new. And it's not everybody's a good candidate for it. You have to have really kind of particular anatomy for there to try to put in a sort of a covered stent to try to redirect blood flow in this area. And then what are the late issues that these patients have? Let's say somebody gets a repair or with a closure device or a surgery. These patients still are at more, unless they're repaired very early in childhood, they run a higher lifelong risk of arrhythmias. Embolic stroke is not particularly common. If there's a residual gap or the patient hasn't been repaired, there is a potential for a small clot from the veins to go upstream against the blood flow occasionally, and that could end up in the head. Endocarditis, again, not super common, but there is a potential for either, if it's an unrepaired defect, for the bacteria to grow along that area, or if there's a residual, things didn't heal completely, and there's a gap of next to an artificial device or a surgical closure patch. Occluder devices rarely cause complications, but sometimes if there's a really big one, sometimes over time it can sort of push into the aorta or one of the valves. And high blood pressure in the lungs, pulmonary hypertension can happen. That's more likely to happen with a big defect that's discovered or closed late in life, or if somebody's got an additional risk factor that puts them at risk for pulmonary hypertension. There are some patients with ASDs that are discovered at 30 or 40 years of age, and they thankfully don't have much in the way of elevated pulmonary artery pressures. Just to switch gears and talk about VSDs, and I probably have to speed up a little bit for time. Sorry, my slides. VSDs are very common. This is among the congenital heart regions. This is kind of showing how common VSDs are in terms of number of cases compared to PDAs, ASDs, all these other sort of lesions, which are much less common. So they're very common among congenital heart lesions. And there are a gap here between the two pumping chambers, between the left ventricle and the right ventricle. And they too can lead to excess blood flow going into the lungs. Again, this is our same sort of box diagram showing the left and the right of the heart. In the atrial septal defect, we see blood flow going in between the atria, making the right atria and right ventricles levels. But if you've got a hole between the ventricular septums, you get more blood flowing into the right ventricle and then the pulmonary arteries, pulmonary veins, but then more blood flowing into the left atrium and the left side of the heart until it balances out at the ventricular level. So this tends to end up in enlarging the left atrium and the left ventricle and the pulmonary arteries and veins, but less so the right side of the heart. And so over time, that again will make the left side of the heart look bigger. So this is how it would look on a chest X-ray, and the pulmonary arteries and veins. And because the ventricles are under higher pressure, this is much more likely to cause problems, to cause pulmonary hypertension. If there's a very small hole, that usually presents, that kind of helps keep the high pressure blood flow on the left side of the heart, and only lets a little bit of blood flow go to the right. That's less likely to cause problems later on in life, like with pulmonary hypertension. But a large defect can cause a lot of problems early on, and some kids can become, if it's a big defect, can become quite sick even at like 2 to 8 weeks of age. A child's heart can sometimes thicken and compensate a little bit better than if an adult had it as a developed one later in life, say as a consequence of a heart attack. But there's a limit to how much a child's heart can compensate for this. And what we worry about much more with VSDs, if they aren't repaired early in life, is that they can lead to problems over time. This is showing the lung arteries, kind of the little tiny branch lung arteries magnified, and that there's this kind of, here shown in light purple, is this muscular layer of the heart, which is usually relatively small, but if the lung arteries are exposed to high pressure over time, that can thicken and end up making the path for the blood flow in the center here very small. And the resistance, the lung arteries can become stiffer. And if it becomes stiff enough, it can make the pressure on the right side of the heart higher than the left side of the heart. And now the blood flow goes in the opposite direction. So blue blood would go out to the ventricles and out to the body, and that can cause somebody to be cyanotic. So the surgeons are much more likely to close these later on. Different ventricular septal defects can happen in different parts of the heart. If they're up here towards the aortic valve, we call them paramembranous. If they're up towards the pulmonary valve, supracrystal or outfall. And if they're more towards the middle or tip of the heart, they're often called muscular defects. And here's one of these atrioventricular septal defects that spans both the atria and the ventricle. In terms of what can be closed in the cath lab, really only the ones that are some of these muscular defects, because all the other defects are too close to valves or other structures. So the vast majority of VSDs that need surgical closure end up being closed by a surgeon rather than by an interventional cardiologist. In terms of which are the most common, paramembranous are about 80%. The supracrystal, or kind of the ones near the pulmonary valve, are about 5 to 7%, except in countries in East Asia. We presume there's some genetic factors that influence that, but that may be as high as almost 30% of patients in that part of the world. Inlet defects are about 5 to 8% of the patients who have VSDs, and muscular defects can range 5 to 20. And you see this, there's a larger gap because sometimes muscular defects that are just towards the tip of the heart, if they're very small, sometimes they will spontaneously close with age. And so that, depending on how quickly you look at a kid, they could go away over time. All right, so sorry, some of these clips are hanging up a little bit. So this is showing all 4 chambers of the heart in this view. So this is the right atrium and left atrium, or right atrium and left atrium, right ventricle and left ventricle. Here's the ventricular septum, this wall of tissue. And here you see this gap here in the center that's connecting the two that shouldn't be there. There should be a solid line all the way here to the center of the heart. Here's another view, a different angle. This is the right ventricle in the top of the screen, the left ventricle at the bottom of the screen. And with this color flow mapping, you can see blood flow from the left ventricle pushing across the ventricular septum, pushing into the right ventricle. And this is, again, a ventricular septal defect in the middle portion of the ventricular septum. And here's another picture, again, all 4 chambers of the heart. And this clip is having a little bit of problem, but this defect is really towards the tip of the heart. So you can see blood flow. This ventricular septum is intact all the way until you get to the very apex of the heart between the left ventricle and the right ventricle. And you can see blood flow going across here. And then here's another one. This is one of those atrioventricular septal defects. So the gap here is right here by the mitral and the tricuspid valves. So you can see that kind of gap right there. Sometimes ventricular septal defects, if they're by the aortic valve, they can ultimately end up distorting the aortic valve anatomy. So this is showing an aortic valve that's kind of being pulled and pushed with different heartbeats, and that can lead to the aortic valve not closing over time. So usually we're going to recommend surgery for medium to large defects. Sometimes small defects, if they're not causing problems, we would maybe just keep an eye on. But if a small defect is distorting the aortic valve over time and causing it to not work as well, that's another reason we might recommend surgery. Other late sort of complications, like any child that has childhood heart surgery is a little bit more at risk for arrhythmias. Embolic strokes can happen, but they're rare because usually that left ventricle is going to push blood from the left ventricle side to the right ventricle side. So unlike an atrial septal defect where the pressure difference is much smaller, there's usually a big pressure difference. So it's harder for blood flow to go upstream and go against the flow of blood to cause a clot to get to the left side of the heart and then to the head. Endocarditis is, again, not super common, but we think sometimes, again, if there's a residual hole near a surgical repair site, that may not heal in as well, that instead of being covered by the lining of the heart over time, that could, if there's a rough edge there, that's easier for bacteria to grab onto. And then pulmonary hypertension is the big one that we kind of worry about in somebody who isn't repaired at a young age or doesn't have a great repair. That can lead to, again, high blood pressure in the lungs. And sometimes if patients come to us and they weren't repaired in childhood, we actually really have to try to treat their pulmonary hypertension with medications. Some of these patients may never have their pulmonary artery pressures get good enough that we can close them surgically, but we can often help them feel better, be less short of breath, be able to do more, and hopefully live a longer life. And just to talk a little bit about the embolic stroke risk for the ASD levels is sometimes, from a nursing perspective, sometimes we ask people to put in IV filters just to try to help catch bubbles. And in most people who have intact septums, if a small bubble gets into a vein and goes through the right side of the heart, it's going to end up in the lungs, and that bubble will get reabsorbed and breathe. Effectively, you'll breathe it out eventually. But if there is an ASD or a VSD, there is a potential, although most of the time the blood will still be directed to the lungs, there's a small chance that it could go upstream if somebody coughs or burps or has bears down for a bowel movement, and that could end up in the head, and that could potentially cause a stroke. So the risk of that is probably very, very small, but we do sometimes recommend putting in an IV filter just to try to help catch those bubbles so they don't enter the circulation. So I think I might be a little bit over time, but let me ask if there's any questions or anything that you guys would like me to go over again, or other concerns about atrial septal defects or ventricular septal defects.
If there are any questions, please just unmute and we can address those questions.
Well, I must have explained things perfectly. I know I did cover it a lot in a short amount of time. Obviously, it's a topic it's very enthusiastic about things in congenital heart disease, and I wanted to give you guys a big overview. Hopefully, I didn't give you too much extraneous detail, but ASDs and VSDs are common. Most patients, again, if they're caught early in life, do well. Some ASD patients present later in life and may still ultimately do very, very well, but there are reasons to potentially close them. Very, very tiny defects may not need closure if there's not enlargement of the heart chambers, if there's not signs of pulmonary hypertension or valve dysfunction from a consequence of these. Sometimes we just keep an eye on these, but anything beyond a very small size is likely to cause other problems, so usually should be repaired later on. And although most patients will do well as they get older, we do want to usually keep an eye on them as they get older, because there are risks of late complications like arrhythmias and valve problems and endocarditis. Again, thankfully not very common, but we do want to see these patients every few years just to make sure that we're staying ahead and doing the right ancillary guidance for these patients as they get older.
Thank you very much, Chris. This was terrific.
Thanks very much.
Great information, and we really appreciate it. We're going to move on to our next presenter, Dr. Ami Bhatt. Dr. Bhatt is the current director of the Mass General Adult Congenital Heart Disease Program. Dr. Bhatt is a clinical cardiologist specializing in lifelong care of teens and adults with congenital heart disease, addressing valve problems, heart failure, multidisciplinary surgery, arrhythmia, pregnancy, transition, telemedicine, and wellness programs. And Dr. Bhatt is dedicated to patient advocacy groups, including the AHA, Adult Congenital Heart Association, while empowering individuals with CHD to lead full and productive lives. Dr. Bhatt is not with us live today, but we have her presentation that I will now share. And Dr. Bhatt.
I don't know if others are having issues. I'm not hearing anything, and I'm happy to talk over Ami's slides if the audio is not working.
Yeah, sorry, Chris, I'm not getting any audio either.
Chris, I'm hearing the audio on my end, but if you want to talk over, that's fine.
I think I'm hearing like it's something very, very soft, but it's not loud enough to make out.
Heart in theory, those two pulses should land at the same time, but you'll notice that there'll be a radial femoral delay, meaning you'll feel radial pulse, pause, femoral pulse next. And so that radial femoral delay is a way, even without the blood pressure cuff, to be able to tell that it's taking longer for that blood to get through the coarcted segment of the aorta and therefore give you a femoral pulse. Now, when we're looking up in the suprasternal notch view of coarctation on the echo, what you'll be looking for is a narrowing here, right around where the ductus would be, so in this kind of periductal area, and you see this acceleration and heterogeneity of flow happening, and so that's kind of one of those examples we look for. And then just like we were talking about the narrowing of the aorta and how long it may take blood to get through there to give you a femoral pulse, you also will notice that instead of just being an aorta that gives you flow and then that flow stops, you have flow and then that flow continues because there was a narrowing all through diastole. There's this continuous flow that's coming through. And so these are, two areas to really focus on the echocardiogram, and ones that we don't see or talk about often, which is why I really wanted to emphasize this right up front when we talk about coarct. We can use advanced imaging, and in fact, one of the key guidelines for coarctation of the aorta is every 5 years, we want to make sure that we get either a CT or MRI to look at the entire aortic vasculature. And so we can see, the aorta here, and then we see this really significant coarct and significant narrowing with almost just a wisp here of a connection between the aorta here and here, right in that juxtaductal area again. We can see other things as well using imaging. And so here you see, this is the ascending aorta. Okay, we can see the SVC was coming in with some dye that was injected, but then you see all these little things here that don't necessarily look like they belong, and those are all collateral vessels. And so these are an attempt for the body to say if there's a significant coarct that's going to be down here somewhere, how does the blood get from this area down to the descending area? And it's really the body creating all sorts of byways or collateral vessels to try and get around that area. And these collateral vessels can exist in many different places, but the mediastinum is one place that we will see them. How do we correct for this? So coarctation of the aorta in children is oftentimes surgical in the youngest years. In the middle years, you may have balloon angioplasty stenting, but really in talking about the adult, we have two options, either surgical or catheter-based, and most people will try and see whether a catheter-based approach could be favorable first before doing a surgical procedure in an adult if the anatomy allows. And so these images are courtesy of our colleague Ignacio Iglesias. And here's an example in A of that coarcted segment, again, looking really quite narrow there in the middle, almost like you have two different vessels here. But then our ability to wire down that area, and then here you have a stent that he's placed to open up this area here in the middle. And so really nice repairs with using stenting in adults for coarctation. It's worth talking about what the surgical interventions are in childhood, just so that you have heard of them. The first is a resection with what we call an end-to-end anastomosis. So if there's a short, discrete area that's narrow, cut that area out, put the other two areas together, sew them up, and that's it, you're done. The other option is a subclavian flap repair for oftentimes a log segment coarct. So if you don't just have a discrete area, but instead there's a longer area that's narrow, what we used to do is if you picture the aorta going right down the middle, and then the subclavian almost like an arm coming off the aorta, we would fillet underneath that subclavian and then down the aorta and then put those two pieces together. And that, your left arm won't fall off, although you won't have a great blood pressure or a great pulse in that left arm. And that's important to know about these patients when you're measuring blood pressure or looking for a pulse. But it'll give you a very nice repair of that long segment coarctation. Sometimes you can do an aortic bypass in these individuals, and other times they used to do a small patch aortoplasty. They would take a little area out where that divot would be for the coarct, and they would try to put a patch over it. It actually turns out that those patches really have a risk of developing an aortic aneurysm right at the edge of where that sewing ring is. And so we will not often do this anymore. And in fact, if we find patients who had a patch aortoplasty, um, we will look for aortic aneurysm formation. Sometimes that looks like a little small, almost like a bulbous area growing out of that suture line. Those are at risk for rupture and will need some sort of repair. So what are the complications long term, or the common cardiovascular sequelae of untreated or late repaired coarct, right? People who present in adulthood who are like this young woman who's untreated, or somebody who is repaired later in life. Those are the populations where you'll see most of this: systemic hypertension, premature coronary artery disease. There can be risk of aneurysm, dissection, or rupture. Sometimes, really, we see infective endocarditis, stroke, heart failure, oftentimes from diastolic heart failure or back pressure, we think onto the heart. And we'll talk about some research we did on that. And then other concomitant cardiac lesions that may cause issues, and a very small risk of sudden death. The key ones that I would focus on here for the average adult with coarctation who has already been repaired is hypertension, premature coronary artery disease, and then either recoarctation of the aorta, especially in the end-to-end anastomosis, or development of aneurysmal dilation in the setting of a left subclavian flap repair, in the setting of having the patch repair, even in the absence of that, checking the whole aorta once every 5 years per guidelines for that reason that you're looking for recoarctation or something else abnormal and dilation in the aorta, because again, this disease is an arteriopathy. So let's focus on systemic hypertension because that's the primary complicating factor we see long-term in coarctation of the aorta. So most common complication occurs in about 30% of children and over 60% of young adults. So this is an incredibly prevalent diagnosis. You may notice this at rest, but you may not catch it at rest. So it's very important that these individuals get either a 24-hour ambulatory blood pressure monitor, or nowadays what we do in our practice is we'll actually send them a Bluetooth blood pressure cuff. And Heartfelt Dreams actually introduced us to the relationship through which we got them the Bluetooth blood pressure cuffs. And they can actually then upload through their phones to our electronic health record their blood pressure readings anytime that they do it. So when they come in for their visit, we can review how things have been. But even in the meantime, if we notice things are changing in between their episodic visits, we can actually contact them. We can talk about what the blood pressures are and how to change them. So again, remembering to monitor individuals more than once a year for hypertension when they have coarctation of the aorta. Um, Systemic hypertension occurs anywhere in the studies from 25% to 80% of adults, depending on which study you're reading, with coarctation of the aorta. Depends on patient age, depends on whether blood pressure is measured at rest, with exercise, or doing ambulatory blood pressure monitoring. You're more likely to catch the blood pressure abnormalities if you do something more than a single blood pressure at rest. And so we really do encourage that. What are the risk factors for hypertension? Those with a left subclavian flap tend to have some more hypertension. Older age at repair is a strong factor in multiple studies. Having a cervical aortic arch, or one that really kind of comes up quite narrow and pointed at the top, we call it a Gothic geometry. We think that's related to the way the blood flows. And then those who have renal abnormalities, other types of vascular dysfunction. Why? Why is there persistent hypertension, right? So there are a couple different theories. One is that there's dysfunction of the baroreceptor, so we're not getting good sensing of what blood pressure should be. The second is abnormal post-repair aortic arch morphology. So there's something that we change about the flow of blood through the aorta, and those flows result in decreased compliance or increased stiffness or increased hypertension. And then the last is just that maybe many individuals are born with impaired vascular distensibility or a stiffer aorta than an age and gender matched population. We talked about recoarctation. I would say these are the two things. Again, we're looking for hypertension in the coarctation adult patient. We are looking for recoarctation of the aorta or dilation of the aorta. And then we're going to make sure as they get older that we don't develop premature coronary artery disease. We'll take care of any of the additional risks that may occur, like if you have a bicuspid aortic valve, watching that aortic valve, etc. For recoarctation, clinically significant recoarctation, less common than hypertension, occurs in about 10 to 15% of adult patients based on which studies you're looking at. It tends to occur most commonly after the end-to-end anastomosis, where we cut out the middle section and we have a suture line that is in the middle of the aorta. Aneurysm formation, more frequent with the use of a surgical patch, as we talked about, or older age at repair. And the Dacron patch material was the most strongly associated with aneurysm formation. So if you have a patient whose history says Dacron patch, that's one where you're going to want to check in with them. Important, again, guideline, 3D thoracic imaging by MRI or CTA every 5 years. So I want to take a moment to talk about the research that we've done in the program here over the past several years around coarctation of the aorta. It's been an area of interest for us and what the complications are over time. And the way I term this is really longitudinal compounding complications because one set of complications tends to beget the next. So let's just start by looking at our cardiovascular risk. We're talking about changes over a lifetime, and we start in the beginning where we have an early childhood repair. So the things we know, one is you're getting surgery in early childhood. The second is there's something intrinsic that you're born with that's an arteriopathy, and that's where we start. We then move to the next stage as we're getting older. We may see hypertension again, exercise-induced hypertension, right? Might be hidden at rest, so important to look for that. Because there is some underlying endothelial dysfunction, we worry that the arteriopathy and the endothelial dysfunction may worsen if we have untreated hypertension because we're not diagnosing it in childhood. So 30% of children will have hypertension, so we should be finding that those 1 in 3 kids who have it. And then as we get older, we start to worry about aneurysm formation or reason to recognize that that is now on top of the other issues we've talked about. And when we change the aorta interacts directly with the ventricle, right? So the left ventricle and aorta are a unit. And if you have a stiffer aorta, an arterial tree, then that left ventricle has to do more work. And so we think about ventricular arterial interaction and what's the load on that myocardial muscle? How hard does it have to work based on hypertension, re-narrowing of the aorta, and arterial stiffness? If there is a lot of those things, we may get early diastolic dysfunction or heart failure preserved ejection fraction. And some of our studies focus on seeing if we can try and improve the arterial stiffness and as a result, perhaps improve the function of the heart. And then lastly, we have to remember that all of these factors can lead to premature atherosclerosis. We have some studies that actually show that we've seen that in this population. So making sure that from a young age, we're really being as heart healthy as possible and that we do cardiovascular prevention for this population, really for all of adult congenital heart disease from a young age. We're fortunate in that adults with congenital heart disease have been with us for a very long time. And so we really have the opportunity to do beautiful cardiac prevention for this population. In fact, if we do it right over time, adults with congenital heart disease should have less atherosclerotic cardiovascular disease than the general population if we're really paying attention and helping guide them through that. The studies that you can see on the left-hand side here, so just a nice reference would be the first one that Dr. DeFeria and I worked on a couple years ago. Zara Motamed did a beautiful paper. This is along with over at MIT, There were labs that were building models of flow. What does an aorta look like? What does the flow look like in coarctation of the aorta? So they took our data from our imaging, from our caths. Dr. Ignacio Iglesias was kind enough to give a lot of this data and patients on their patients to them. And they were able to take a look at what does the flow look like and what happens when you do this flow. So let me show you for a second. These are simulated aortic flows. And so they really had flow measurements. They had models, three-dimensional models of aortas for each individual patient whose data we gave them. And they used the patient data and they looked at before and after intervention. What was the peak pressure by catheter? And here you see about 15 in this, individual, just as an example. And what happened afterwards? This peak pressure went down to 5 because the patient was stented by Dr. Iglesias. Um, and then they create a simulated model. Can we, in our computer, create a model that shows you how that same thing happens? And they did that for both catheter, they did that and validate for Doppler echo. When doing this, the exciting part is we did a really good job. People who had a gradient, these are people with low gradient coarctation of the aorta, not those with a gradient of 30 or 40, but those with 20 where we thought, gee, for some reason, clinically, we think it is valuable to fix these people. And that reason varied from on multiple hypertensive agents, wanting to prevent people from having diastolic heart failure, other reasons that we thought was what we thought we were appropriate. Now, when we do that, it's important to recognize, oh, I cannot go back a slide in this, can I? It appears that I cannot, I can only go forward. Okay, when we did that, don't look at this slide for a second. What we realized is that in these individuals where we were creating the models of the aorta and studying how they look before and after stenting, we did a beautiful job of decreasing their gradient to 5 or less. We really opened up that aorta. However, the load that the left ventricle saw, right, the work that the left ventricle had to do against this aorta did not change at all. So the work the heart was doing, pressing against a coarct, right, and pushing out against a coarct, was no different than that of having a stent in place. And so important lesson to be learned about thinking about the flow that is happening and what compliance looks like in the arterial tree, and recognizing that, yes, we got rid of the gradient, but that didn't necessarily prevent the load that the myocardium was going to see over time. And so really helped us rethink that physiology in those individuals. The next study that was on that list was by Yamini Krishnamurthy, and she was looking at CAT scan in these individuals, the cartilage of the aorta, and getting a sense of what the calcium score would be as an interpretation of what their risk of coronary artery disease would be. We had a later study that actually looked at subclinical atherosclerosis, so actually looked at whether or not there was plaque in the arteries, and we did see that individuals with coarctation of the aorta have plaque at a younger age than individuals who don't have coarctation of the aorta. Here's the calcium score. The top one is quantitative and the bottom is qualitative, looking at how much calcium can you see. And this was in fact in chest CTs done for other reasons as well. So this qualitative down here is if you happen to come in with question of a pneumonia into the ED and you get a non-gated chest CT, you can actually read some calcium off of that qualitatively. You need to be gated to be able to do quantitatively. And you just see here, if you get to the age of over 40 years, this doesn't bode well for some of us, with coarctation of the aorta, you can see how the percentage changes here of developing a higher calcium score as you age. And so here 22% had kind of a low, moderate, high calcium score on quantitative. And then we could even see on the CAT scans that were not specifically done for these individuals for their kind of 5-year gated chest CT, but happened to be for some other reason, again, really a higher prevalence of individuals who had minimal, moderate, and severe calcium qualitatively, and then those who had even multiple vessels with calcium. And so we're most certainly seeing at an earlier age individuals with coarctation of the aorta having the presence of calcium and having the presence of subclinical atherosclerosis. So I'll end here with the guidelines. Again, we've said initial and follow-up aortic imaging using cardiac MR or CTA is recommended in adults with coarctation of the aorta. including those who have been repaired with surgical or catheter intervention, not just for Native individuals. Resting blood pressure should be measured in the upper and lower extremities. And I would dare say that by the next time we create the next guidelines, we are definitely going to say that we should also have exercise blood pressure, hopefully as a class 1 guideline by then, or ambulatory blood pressure monitoring using Bluetooth blood pressure cuffs, which can be at rest or then at exercise. Surgical repair or catheter-based stenting recommended for adults with hypertension and significant native or recurrent coarctation, and then please treat the hypertension, right? 30% of kids, over 60% of adults with coarct will have hypertension. Please use guideline-directed medical therapy as you would in anybody else. And then what we've done is we've created routine follow-up and testing intervals based on the patient's diagnosis, coarctation here, and then their physiologic stage. And based on whether you're doing kind of very well with really no complications, stage A, stage B, perhaps you have some complications, you're not as active, and then progressively to C or D, we tell you how often people should see their adult congenital heart disease team, as well as which type of testing they should get and how often. I'll end with this. Really important to recognize that when we're talking about coarctation of the aorta, these may be individuals who as a child did need to have procedures, one or multiple. And as many others with adult congenital heart disease, there was a stage, which we don't do now, where we really did exercise restriction rather than exercise prescription. But it is not too late. So for adults with congenital heart disease, for those with coarctation of the aorta, aerobic exercise, more so than isometric, is recommended. And the way we say is we should assess activity levels with our patients. We should talk about it. We should talk about the types and intensity of exercise that would be appropriate to their specific clinical status. We can use testing to guide them. We can use cardiac rehab if valid to increase their exercise capacity. And then lastly, we need to also recognize that lifelong chronic disease can be challenging, and we do have high rates of anxiety and depression really in all of the United States right now, but especially in patients who have complex disease. And so patients with ACHD do all need to be evaluated for depression and anxiety, and we should figure out how to have our programs do that somewhat regularly. We're really fortunate to have a great team, and Lauren McLaughlin, who you hear from today, was one of the first people to recognize that we needed a separate clinic where we just concentrated on the health and wellness of our patients, where we didn't really think about what's coming next, what's the next valve disease, what's the next test, but we said, how are you and what is happening? And really had times where we were talking about how can we make you better. We even did in-office meditation for a period of time out in our Waltham office. And so really important to recognize that our team-based care is incredibly important, but that we also need to think about the patient holistically. You'll also be able to hear from Sharon Gallagher about exercise in these individuals, and I'm really excited for that myself. So thank you all for having me. And again, nothing can be done without the multidisciplinary team, but when you put all of us together, we can absolutely be a force to be reckoned with in order to really help our patients live better and longer lives. Thanks very much again.
Well, thank you all. And it's my pleasure now to introduce again, Dr. Doreen DeFaria-Yeh. Dr. DeFaria is the Associate Director of the MGH Adult Congenital Heart Disease Program, co-director of the MGH Cardiovascular Disease of Pregnancy Program, and Program Director for the Cardiovascular Disease Fellowship. Dr. DeFaria is a clinical cardiologist focusing on ACHD, pregnancy, and cardiovascular disease, particularly high-risk cardiac conditions in pregnancy, as well as echocardiography with expertise in ACHD echocardiography. Dr. DeFaria, please take it away.
Great. Thank you so much, Eric and Lori for sponsoring this great sessions, 2 terrific talks about some important congenital heart lesions. And it's my pleasure to talk today about tetralogy of Fallot. This in our congenital heart clinic is one of our more common conditions that we see, although not common in the general population, but a really important congenital heart population of patients that we just absolutely love taking care of. One additional shout out and thanks to the Heartfelt Dreams Foundation. I want to highlight Eric and Lori's work. And Lori, you'll read on their website, was born with tetralogy of Fallot, and certainly it's been such an honor to be part of her health and her care over the years, and know that she's been the inspiration for so much in this foundation's work, and helping others learn from the experiences she's had in her life. So thank you to both of you. I'll talk a little bit today about tetralogy of Fallot. We'll talk about we'll talk about what tetralogy of Fallot is and the common complications that we may see in adult clinics. We'll talk a little bit about the surgeries and the procedures, and then we'll also just spend a few minutes talking a little bit about pregnancy considerations with tetralogy of Fallot. This is a graphic that I start many of my congenital heart talks with. This was published in a textbook in the 1960s, and is a graphic that at the time, before the era of advanced pediatric cardiac surgery, demonstrated the expected life expectancy of patients born with different congenital heart conditions. So on this axis here is percentage of death here, 100%, 0% on this axis. On this axis here is age in years, so 10 childhood to 70. And if you look at the normal graphic here, back in, I believe this was 1964 when this was published, the average adult lived on 50% of patients lived a little bit over their into their 70s. Of course, the average life expectancy has increased now in the current era. Among people born with congenital heart conditions, the average life expectancy was significantly lower, even among people born with what we call more simple congenital heart problems like ventricular septal defects or atrial septal defects. You see about 50% of them only made it about into their 30s or 40s without surgical correction. So the advent of cardiac surgery remarkably changed the long-term trajectory for congenital heart patients. But you'll know here, note here, tetralogy of Fallot, or Fallot's tetralogy as noted then, 50% of kids did not make it past age 10 if they did not have a surgical correction in childhood. So the long-term outlook for kids born with tetralogy of Fallot before the 1950s or 60s was quite poor. And so many of our patients remember stories of being told, or their parents telling them, oh, nobody expected you to live this long, or, you know, be here, because we really didn't know at that time how these kids would do if they underwent surgical correction. But cardiac surgery has dramatically changed the long-term outcomes of patients, particularly with tetralogy of Fallot and other complex congenital heart disease, such that we see many of them in our adult clinics. And now we have to think about what are the long-term complications we need to manage moving forward. So the percentage of patients with congenital heart disease has grown remarkably over the decades as a result of fantastic advances in pediatric cardiac surgery and pediatric anesthesia. The pie, if you will, or the number of congenital heart patients has grown quite a bit over the decades, but importantly, the red portion of this pie, the number of adult patients with congenital heart defects, has very significantly increased. So it's truly important for all of us as providers and whatever role group we serve on a team to really understand congenital heart disease, because these patients are coming to us, and there are more of them that will be coming to us over time. Interestingly, patients with congenital heart disease who have been referred to a specialty center do better. So this is a graphic that shows over the years here on this axis, when our guidelines came out talking about the importance of specialized congenital heart disease centers in the mid to late 1990s, we saw the number of referrals of patients to specialized centers went up very significantly. And importantly, we saw the number of deaths in the congenital heart patient population decrease with the increase in referral to ACHD centers. So the more patients are referred to specialized centers, the more we can impact long-term survival. This is a very powerful graphic. And for those of you in the audience who may not know where the nearest specialized ACHD center is, please reach out to us. We're happy to help connect you with our colleagues across the country to connect your patients with specialized ACHD centers. This is yet another graphic more recently showing survival on this curve. And years of follow-up among patients who are with congenital heart disease who are either referred to a specialty center or cared for not at a specialty ACHD center. And again, this demonstrates that survival is better in the long term with specialty care. And why is that? There may be some unique complications of early childhood surgery that are hard to pick up unless we're looking for them specifically. And that's what I'm going to talk about today. Some of the things we need to actively look for with tetralogy of Fallot to ensure best outcomes. And here's a graphic of some of the ACHD centers. Again, certainly not enough centers in many parts of the country, but reach out to us if you need help connecting with your local ACHD expertise. So tetralogy of Fallot, this, as I mentioned, is a common congenital heart condition we see in our clinic. It's 4 problems, so tetralogy. We'll see all of these patients are born with a sizable, usually a sizable hole in the heart in the ventricular septum, the ventricular septal defect. They're also born with the aortic valve here that is deviated anteriorly and to the right. And the embryologic lesion that causes this is this conal septum here, the tissue between the aortic valve and the pulmonary outflow tract is deviated anteriorly. It brings with it the aorta to sit more over on the right side of the heart, and it crowds out this area below the pulmonic valve, giving us pulmonary stenosis or narrowing of the blood flow moving from the right ventricle to the pulmonary artery. As this aorta is pushed up here rightward, we call it overrides the ventricular septum. It kind of sits and straddles between 2 ventricles here, and then the ventricular septum cannot fully form embryologically, and we have this ventricular septal defect. So if we think about that, we can understand all the various parts, the pulmonic stenosis and the secondary right ventricular hypertrophy because of the high pressure in the right ventricle, pulmonic stenosis, right ventricular hypertrophy, the overriding aorta, and the ventricular septal defect. Now, there's many variants of tetralogy of Fallot, and often the severity of tetralogy of Fallot really depends on how obstructed the right ventricular outflow tract is. So the area below the pulmonic valve, called the infundibulum, is obstructed by often these muscle bundles that kind of crowd out this area, and that tissue just makes it very small and crowds it. This is a pathologic specimen with the right ventricle open. We're looking at the septum here. This arrow is pointing through the ventricular septal defect, and here is our right ventricular outflow tract. And you can see where this little marker is that there is this muscle bundle that sits across that area. This muscle bundle is further obstructing that right ventricular outflow tract. The more obstruction through the right ventricular outflow tract, the less blood to the pulmonary arteries, and often the more desaturated those babies might be. Often the more obstructed the right ventricular outflow tract is here, the more blood flow that's going to go the wrong way through that VSD, the more right to left shunting, and we'll see more cyanosis in childhood or desaturation in those babies. Kids who have mild RV outflow tract obstruction, so less blockage in this area, will have more blood flow to the pulmonary arteries, and will have less blood flow going right to left through this VSD. We used to call this term pink tetralogy, meaning they weren't so desaturated with low oxygen level, but these are patients who have lesser degree of RV outflow tract obstruction. The most severe variant of tetralogy of Fallot is what we call pulmonary atresia, where this area here in the right ventricular outflow tract is so narrowed that really that pulmonary artery just does not develop well. Blood flow really can't get to the pulmonary arteries, and these babies are very, very blue when they are born. So the degree of RV outflow tract obstruction is really important to determining how blue or how sick those babies are when they're born. Many may remember many years ago, before we had the opportunity to do pediatric cardiac surgery in very, very small babies, children with tetralogy of Fallot would often have to deal with low oxygen levels. And often when they would go to school and they would start running around and exercising on the playground, we would see more desaturation, or they would become more blue. Their lips would turn blue, their fingers would turn blue. And these would be called TET spells. The kids may even, pass out or because of the low oxygen level. Well, why does this happen? When kids are running around or exercising, there may be a drop in the systemic vascular resistance that could increase right to left shunting, with the ask of the heart to increase blood flow to the pulmonary artery. And those two things, with the increase in right to left shunting, would cause more desaturation. Kids may also present with arrhythmias early in childhood and in small babies. I won't get into the pediatric presentations, but poor feeding or poor growth, also important signs of trouble with cardiac function in children. When these episodes happen, what would kids do? They would actually squat down. And what does that do? That increase in the systemic vascular resistance increases the afterload to the left ventricle and prevents some right to left shunting. And kids would know, they're smart, that if they squatted down, that would make them feel better. Often their oxygen levels would go up a little bit. So it used to be years ago, before we could have small babies undergo cardiac surgery, we wait till kids would start squatting, and then we say, okay, well, this is our moment now to fix their tetralogy of Fallot. Many years ago, before babies could undergo complete surgical repair with cardiac surgery, we may have considered doing what we call a palliative shunt, or bringing more blood flow to those baby pulmonary arteries, since they were not getting enough blood flow from the inherent pulmonic stenosis with tetralogy of Fallot. This is Dr. Helen Tausig, who was just an unbelievable legend in the field of pediatric cardiology, who made an observation that babies who had a patent ductus, or had a natural connection between the aorta and the pulmonary artery, did better. They had more blood flow to their lungs. And so she thought, with the help of a few friends, Dr. Alfred Blaylock and Vivian Thomas, they thought together, well, if we created a shunt like a patent ductus, or like a ductus that connected the aorta to the pulmonary artery, maybe these babies would do better. And thus the development of the Blaylock-Thomas-Tausig shunt, where the subclavian artery is utilized to be connected to the pulmonary artery, either an end-side anastomosis, we call the classic BTT shunt, or a tube graft between the two, we call a modified shunt. And this allowed more blood flow to those baby pulmonary arteries, so they could grow and they could develop, and that baby could get big enough to ultimately undergo cardiac surgery. And many of our older patients with tetralogy of Fallot had these types of shunts earlier in their lives. It's important for us to know that they had these shunts, because there are some complications that can develop over time in people who had these shunts. In case you run across these terms, the Potts shunt or the Waterston shunt, other types of shunts that were created to increase blood flow to the pulmonary artery circuit. Today, babies can be diagnosed with tetralogy of Fallot with fetal ultrasounds and fetal echocardiography. It's quite remarkable what we can see in the fetal heart at very, very early stages of gestation to make that diagnosis early. And today, many of our children and babies can undergo cardiac surgery at a very early age, even a few days or a few weeks of life, and they may not necessarily need these palliative shunts. They'll go straight to a surgical correction of their tetralogy of Fallot. It's a really remarkable advance in surgical technique over the decades. What is that surgical repair? Well, essentially, the heart here, the pulmonary artery that's narrowed, is opened up or incised. And when you open that area, right below you, what you see is that ventricular septal defect. The surgeon will patch up that ventricular septal defect, and they will then relieve the RV outflow tract obstruction, relieve that narrowing by either opening it up, putting a patch in place in that area. So now we have both corrected the VSD, so there's no more mixing of blood flow, and we have relieved that RV outflow tract obstruction, which was causing limitation in blood flow to the pulmonary arteries. And this is what we call the surgical correction. It's not a cure, but it is a repair of the underlying defects with tetralogy of Fallot. There are a few other variants of surgeries that patients with tetralogy of Fallot may have had. If they have a very, very small pulmonary artery, they may have gotten a tube or a conduit between the right ventricle and the pulmonary artery, sometimes called a Rastelli conduit, that can allow blood flow to just bypass that tiny little pulmonary artery and go directly to the main pulmonary arteries here. So what do we look out for among adult patients who had these surgeries early in life? Well, there's so many things that could happen or develop. They could get residual leaks or narrowing at the areas that were previously repaired. VSDs can redevelop, pulmonic stenosis can redevelop. One of the most common complications is that pulmonic valve can get very leaky. And as that pulmonic valve leaks, it can make the right ventricle dilate significantly. With that dilation and enlargement of the right ventricle, that right ventricle could get weak over time. Patients may develop some extra fluid in the right heart or clinical right heart failure. They may feel very tired or fatigued and just not have a lot of energy because their right heart is under a lot of stress. They may develop ventricular arrhythmias and rarely may present with sudden death, which is tragic. And we do everything we can to prevent that. They may also have secondary left heart pump weakness as a result of the weak right heart pump. And they may have aortic abnormalities or aortic enlargement. But pulmonic regurgitation is one of the most common complications we see in the adult clinic. And importantly, it can be very easily missed by echo if you're not specifically looking for it. And this is part of why patients with tetralogy of Fallot who've had surgery years ago should have their imaging reviewed by somebody who has, that expertise in ACHD to pick up some of these complications that can happen after these early surgeries. This is a patient who had been seen early in life and then was sort of lost to follow-up, was feeling pretty good, didn't really have any complaints, didn't feel they needed to necessarily come in and see a cardiologist. And then all of a sudden one day they felt dizzy and passed out. And my goodness, they walked in the emergency department with ventricular tachycardia, so not a good rhythm to walk into the emergency department with. And when we got their MRI, here's the right ventricle, here's the pulmonary artery, we saw this big unusual aneurysm of this area that had been surgically corrected. And around this area certainly is a source of that ventricular arrhythmia. They also had very severe pulmonic regurgitation with a very dilated right ventricle and evidence of heart failure on exam. This patient underwent surgical correction of this whole area in their pulmonic valve and felt much, much better. But boy, wouldn't it have been nice to have prevented what was almost a sudden death event for this young patient. Thank goodness they came into the emergency room in time, but not all patients are so lucky. So when we think about when is the best timing for pulmonic regurgitation, we have to think about what is the natural evolution of how things change over time. Patients get their surgical correction often very early in life, and it's usually not for many decades that they may have problems related to pulmonic regurgitation. The symptoms are very insidious: fatigue, having less energy, not feeling great, maybe some palpitations of the heart. They may not necessarily think it's a big deal, but in fact, a lot is changing in their heart. Their right ventricle might get dilated, the function of the ventricle may decline, they may develop right heart failure, and if the heart really fails to a point where the muscle is severely impacted, sometimes we have to talk about heart transplantation because the heart muscle has been too severely affected. So we realized some years ago that we can't wait until people develop heart failure and all kinds of problems like this before we intervene, because we may not have the opportunity to actually make things better with our surgical intervention to fix that pulmonic valve. This editorial came out, now it's about almost 25 years ago, saying, gosh, are we operating too late with tetralogy of Fallot? Are we waiting too long and letting these RVs, right ventricles, get bigger and bigger and really abnormal and myopathic? And the answer is probably yes. For a lot of years, we were probably waiting too long to do that pulmonic valve replacement, and those ventricles really didn't get fully better after the surgery. Now we have better guidelines about when is the best time to fix pulmonic valves. We really rely on MRI. MRI is critical to evaluating adult patients with tetralogy of Fallot. It gives us so much information: the size of the heart, the function of the right ventricle, how much leakiness there is. And we learned that when the right ventricular volume, so this right ventricular end diastolic volume index, a lot here, but a size essentially, right ventricular diastolic size, is not too big, and we did the pulmonic valve replacement, all those right ventricles normalized. So we caught them in a moment. We could really fix that heart, make that right ventricle better, and prevent problems. If the right ventricle is very dilated at the time we meet a patient, and then we fix the pulmonic valve, maybe we fixed the valve problem, but they still had a very severe ventricle problem. So we've realized that we have to intervene on these pulmonic valves before the right ventricles get too big. Otherwise, we may not have an opportunity to really make people better. The guidelines have evolved quite a bit over time to recommend pulmonic valve intervention in an earlier stage. Sometimes this is the stage where the patients don't really feel too bad and they're just a little tired, but they're not really noticing too much. But after we fix that pulmonic valve, they often feel like, wow, gosh, I didn't realize I could feel so good. I feel a whole lot better. So I've left this slide in here for your reference with our current guidelines about timing of intervention. The other piece I'll comment to that point about patients not really realizing how, how limited their heart might be is an exercise test study looking at cardiopulmonary exercise tests in a whole bunch of different congenital heart patients. And you'll hear a lot more about exercise from Sharon Gallagher, our expert in exercise and CHD. But the peak VO2, which is a marker of kind of overall health of the heart and the body's fitness and our body's ability to use oxygen, these are healthy subjects here, normally declines with age, but you'll see in patients with congenital heart disease is actually very low relative to their age-matched counterparts. They have lived with lower exercise capacity, so they often may not know when things are changing or when they're more limited. So we strongly rely on quantifying their exercise capacity with CPET. Tetralogy of Fallot is this bar here with the single lines. You can see the peak VO2s at any age range are significantly lower than their age-matched counterparts who've not had cardiac surgery. So important that we quantify their exercise capacity and use this information. We know that if that peak VO2 gets low, it's an independent predictor of hospitalization and death. These are the things we are looking to prevent. So patients' symptoms are important, but then objectively, what their heart can do is even more important. And if the peak VO2 is low, we need to move ahead and think about the surgical corrections to help that heart get better. Thankfully, we've had a tremendous advent in percutaneous technologies. You'll hear so much more about this by Dr. Ada Stefanescu, who is coming up next, about all of the wonderful interventions and options we have now with a catheter-based intervention and catheter-based valves that can now help to relieve pulmonic regurgitation in some patients. Not all of our patients will be eligible for catheter-based pulmonic valve replacement options, but many of our patients may be. And part of our job in our center here is to evaluate our patients carefully to determine, is the next procedure a surgery as the best next option in thinking about your life and long-term trajectory, or is the next best intervention a catheter-based procedure, knowing that there may be other interventions in the future. We're always thinking about the very long-term health of our patients. We want our congenital heart patients to be very old, enjoying life, not being in the hospital, not having heart failure. And so anytime we think about or talk about interventions, we think about with that long-term hat in mind. Briefly about pregnancy and congenital heart disease, just very briefly. Now that most patients survive to adulthood, there's unique considerations we think about family planning, unique anatomic, physiologic situations that may be unique to women with tetralogy of Fallot if they were to get pregnant, including heart failure, blood clots, and abnormal heart rhythms. And so we really take pride in our program in taking care of our patients and their whole family, particularly during times in life where a pregnancy may pose increased risk to their heart. Just so everyone is aware, cardiovascular disease is an important part of pregnancy-related complications in the United States, all these cardiovascular reasons for maternal death, but also maternal morbidity, so just complications around the time of pregnancy. We as cardiologists have to know how to take care of pregnant women with cardiac disease to improve their outcomes. Maternal mortality over the decades got a lot better across the world, and then in recent years, for a variety of reasons, has increased. There's many things that go into this, including insurance coverage and racial disparities and the complexity of cardiac disease that women may live with now going through pregnancy, but we really need to do a better job of improving maternal outcomes. There are many unique situations, and Dr. Bott and I created this little graphic a few years ago for our congenital heart patients that pose risk in pregnancy. They may have heart pump issues, they may have prior arrhythmias, they may have pulmonary hypertension, aortic dilation, valves, blood thinners, hypertension, you name it, and all of these things need to be carefully thought about. With tetralogy of Fallot specifically, this is a graphic showing cardiac complications in pregnancy with a variety of the different congenital heart lesions. I'll just point out here tetralogy of Fallot with increased risks of arrhythmia and heart failure with pregnancy. So particularly important that we manage these women and monitor throughout the pregnancy to prevent these complications for mom's health and for baby's health. So to wrap up, tetralogy of Fallot is a common congenital condition that we see in the congenital heart disease clinic, and outcomes are improved in specialized ACHD centers. Tetralogy of Fallot can be picked up by fetal echocardiography, and that can allow us to help planning in those early childhood days and weeks to determine the right procedural intervention for that baby. Despite great pediatric procedures in childhood, adult patients with tetralogy of Fallot will have complications later in their life. Tetralogy of Fallot is not cured, it is repaired, and we have to be vigilant about looking for those late complications that can occur in adulthood, whether it's pulmonic regurgitation, whether it's ventricular arrhythmias or heart failure. We need to actively screen patients and look out for these things so that we can intervene in an opportunity where we have time to actually make things better and make those right ventricles better. Symptoms are important, but we always quantify exercise capacity with cardiopulmonary exercise testing. It's an invaluable tool in our clinic. Careful management during pregnancy is critical for mom and baby outcomes. And then lifelong care is absolutely essential. And the wonderful thing about taking care of congenital heart patients is having the opportunity to take care of them over their lifetime, and that longitudinal relationship that we develop through their life as things in life change, as their hearts change, and ensuring that we're really thinking about their long-term health, preventing problems when we can, and supporting them in every way that we can. It's been such a pleasure to be here today, and I'm more than happy to take questions at any time, particularly at the end of our session.
Thank you very much, Dr. DeFaria. We certainly can hold questions to the end if you prefer. And with that, I will move on to our next presentation. Dr. Ada Steminescu is an adult congenital heart disease specialist and interventional cardiologist. Her clinical practice and research focuses on interventions to increase quality of life and longevity of adults with congenital heart disease.
And thank you for the opportunity to speak with you today about cardiac catheterization in adults with congenital heart disease. It is my pleasure to be part of this year's seminar. Thank you to the Heartfelt Dreams Foundation for their support of this program. I'm sorry that I'm not able to be with you live today. Please do not hesitate to send me any questions afterwards. These are my disclosures. Today we will discuss special considerations around cardiac catheterizations in adults with congenital heart disease. First, it is important to remember that we are meeting patients with congenital heart disease as part of the lifelong journey with the disease. While some may have just been diagnosed, others and their families have been impacted by their disease since before birth. Most of our adults with complex congenital heart disease had diagnostic cardiac catheterization at young children and may remember those experiences. There's a multitude of diagnostic and interventional procedures that are appropriate for different diagnoses at different times in life. In particular, in younger children and adults, less invasive options and those without ionizing radiation are preferred when possible. The journey of many adults with congenital heart disease includes multiple tests and procedures in childhood, often followed by a period of being well and relatively free from procedures or interactions with the medical system as they're in their teenage years, and sometimes falling out of care as early adults. As they reach older age and may need repeat interventions as they grow their childhood interventions, for instance, or need their reassessment of their hemodynamics, they may worry that it will trigger another period of complex procedures and surgeries and ill health. When considering or planning for a cardiac cath in adults with congenital heart disease, preparation is 90% of the game, and it starts with a clinical visit. Knowing the prior anatomy, surgeries, and prior catheterization is critically important. Having those details in the original reports is really helpful. It is important to know whether the iliofemoral arteries and veins, as well as the IVC, are known to be occluded as a complication of childhood procedures. It affects choice of access and planning of the procedure. We start with a physical exam. Are there scars in the groin? Are the arterial pulses good in the legs? Is there signs of venous congestions or varicose veins? But oftentimes robust collaterals have developed over time and we may not be able to tell on physical exam. In those cases, we need to obtain cross-sectional imaging, so that is CT or MRI or angiograms during the procedure. Knowing if in prior reports it was noted that some of the vessels were occluded saves a lot of time and possible need for additional radiation or tests. Knowing what devices were used in the past, in particular exact size and make and model of the valves, size of the conduits, is also really helpful because it helps us know what size balloons and stents and valves we need to be able to plan for, and also how big we can make the conduit or the stent in the future. Discussing anticoagulation, whether it's safe to just stop the anticoagulation for 2 days before the procedure, or whether a plan for bridging needs to be made, is important. We also need to consider signs of renal dysfunction. In particular, in cyanotic patients, their creatinine may actually underestimate the degree of renal dysfunction, and we sometimes have to be more mindful in terms of prehydrating our patients or admitting them before, making sure that nephrotoxin medications are held. Especially in young patients, they may not realize that if they have a headache or back pain or something else happens to them, taking NSAIDs frequently, especially before a cardiac cath procedure, can be harmful. We also have to consider the degree of polycythemia in patients with cyanotic heart disease. A hematocrit in the 50 to 55 range is sometimes considered dangerous before a procedure, as patients might get even more dehydrated before the procedure and have a risk of having a stroke or more blood clots during the procedure, and sometimes we treat that before they come into the lab. We also have to think about allergies. Allergies to antibiotics are important. We all know that we see many patients who are supposedly allergic to penicillin in childhood. Having some time to investigate that and trying to figure out if they should be tested, if maybe cephalosporins can be given, if they've tolerated those in the past, can be pretty helpful to avoid having to give vancomycin at the time of the procedure. In addition, in patients who are going to have a device put in particular ASD or PFO closure devices, trying to figure out if they have a previous severe allergy to nickel is important, as it may actually make the procedure unsafe, or may need to take the time to have them seen by an allergist to do formal testing. We should also make sure that we review all their other medications, talk about contraception in particular. The next step is thinking about the safety of sedation and anesthesia. Many of our congenital heart disease patients may have head and neck anatomical variation. Patients with Down syndrome may have atlantoaxial instability, which makes intubation high risk. They may have had prior airway interventions, such as hypoplasia or stenosis if they've been intubated for a long time as kids, especially in younger adults. They may have obstructive sleep apnea that may not have been diagnosed yet, and it's a good idea to screen before thinking about conscious sedation for a procedure. We take time at the pre-procedural visit to discuss conscious sedation or general anesthesia. Many procedures can be done with either, and we turn to prefer conscious anesthesia when feasible, but especially for longer procedures or those that may have a higher risk of complication that may require rapid management, general anesthesia is preferred, or of course if a transesophageal echo is required for guidance during the procedure. We also have to discuss as a whole team whether an anesthesia consult is needed to discuss those head and neck abnormalities or to try to figure out what the best mode of sedation is. We discuss ahead of time radiation reduction techniques. Is there information that's already been obtained from an echo or that could be obtained from an MRI ahead of time, which may make the cath procedure itself shorter. We also discuss with our colleagues whether surgical backup is required or what planning may be available. For some more complicated patients, when we're planning higher risk interventions, they might actually see the surgeon ahead of time and discuss that. In very, very, very rare cases, they might go in for the procedure, and then either because we're not able to do it or because there's a complication, they may need to go to surgery right away. There are some procedures that we will plan to do only on days when our surgeon is available. Extremely rare, he'll need to be with us during the procedure. And then in some cases, we have to discuss whether a hybrid intervention would be more appropriate, whether that's something that we can do as a hybrid in the hybrid OR with us and the surgeon at the same time, or whether that is something that we could do in a staged fashion. All our patients have actually really appreciated meeting the surgeon, especially when he's as wonderful as Dr. Cameron. And importantly, we have to help our ACHD patients be prepared themselves. Most have prior experiences they bring with them. They may have vague or very vivid memories of prior caths and procedures. Their parents may have strong emotions as well, in particular in young adults whose last procedure was in infancy. We can all imagine the stress that brings back. In some patients, it brings back symptoms of PTSD, which require time and a team approach to manage, both for the patients and their families. We also spend some time discussing Depending on the hospital workflow or setting, what their experiences have been between transition between pediatric and adult centers. Patients oftentimes will have very different expectations of the process, and it helps to ask them and ask their families what they expect, and also to discuss in some detail what the pre-procedure is going to look like, the procedure itself, and afterwards. Many young adults may have been treated at pediatric hospitals, where general anesthesia is used much more commonly, where sedation is started earlier, where family involvement is much more pronounced. I prepare my patients to what the process and experience in pre-op will look like, whether the family can be there or not, especially with the COVID visitor safety restrictions that are in place now. I discuss the benefits of conscious sedation, both for the recovery and also for their hemodynamic data that we need to obtain if it's safe.
Other particularities of caths in adults with congenital heart disease is that access is oftentimes more complicated. We oftentimes use femoral access, and it might take us longer to find the appropriate vessel. When there's fibrosis or scarring from prior procedures, it's particularly painful to obtain access, even just to do the lidocaine anesthesia at the beginning. The anxiety around the procedures makes sedation more difficult. The usual regimen of fentanyl and midazolam is not quite as effective when the patient feels themselves very anxious, and sometimes that starts with a first lidocaine injection that may be very painful. Using lidocaine cream prior to procedures can help from that point of view. And then even more importantly, being prepared for the procedure will be like having a calm and peaceful environment. Having the patient use meditation or music can be quite helpful, and they're sometimes really essential in addition to the usual conscious sedation that we use to make sure that the procedure is well tolerated. We always discuss radiation reduction and mitigation techniques. I already mentioned making sure that we know all the information that we obtained from studies ahead of time so that we can be most efficient and not get duplicate information, trying to do things without radiation, making sure the patient is well shielded, and that we always use all the techniques with the positioning of the II and the low-dose fluoroscopy and low-dose cine angiography that we can use. The procedures that we have to improve quality of life and longevity of adults with congenital heart disease are really wonderful and progressing very rapidly. With your care and that of the whole clinical and surgical teams, our congenital patients are actually reaching their 50s and 60s and older and developing acquired heart disease as well. And I think that the crossover between coronary procedure and structural heart disease procedures and those interventions to help our congenital heart disease patients is really a fascinating area. One illustrative area of rapid progress are transcatheter pulmonary valves. The first valve was implanted in a child 22 years ago, just 22 years ago. That really paved the way for the transcatheter valve revolution. It was actually only 2 years later that the first TAVR valve was implanted in France. An improved design of the first transcatheter pulmonary valve, the Melody valve, was approved in 2010 in the US, just 12 years ago. And in the last 5 years, we've had formal approval in the US for use of the SAPIEN TAVR valve in the pulmonary position, as well as for 2 specifically designed systems, the Harmony Altara valves, for patients with large native RV outflow tracts. There are several other valve designs approved or under investigation in Europe and Asia as well. We were very happy to do our first 2 Harmony implants earlier this year with great results and are preparing for our first Altera procedures in just a few weeks. The advantage of transcatheter pulmonary valves as an additional tool in the lifelong journey of valve replacement and repair is the very rapid recovery. Often patients are home the next day. There's a lower risk of complications, in particular in patients who have a dysfunctional right ventricle to start out with. And we also avoid a sternotomy in patients who will usually need multiple procedures over the course of their life. In terms of post-cardiac catheterization care, we usually resume anticoagulation a day after the procedure, sometimes 2, depending on the risk of bleeding. We want to make sure that the access site is well healed, especially in patients who go home afterwards. That, of course, depends on their risk of thrombosis and their indication for the anticoagulation in the first place. We should discuss whether antiplatelets or anticoagulation are required. There's oftentimes wide clinical variability. We don't have great studies for many of the devices to know what the perfect regimen is, and so it's important to discuss with the interventionalist as well as their clinical team, because their response to prior procedures or prior events may alter what we decide to do. We ask patients to monitor, and we sometimes monitor them for new arrhythmias, especially after implanted intracardiac devices. We monitor volume status. We oftentimes will use contrast even for diagnostic or right heart catheterization procedures to look at baffles, to look for leaks. And so they may have received quite a little bit of IV fluid and contrast during the procedure. And oftentimes, to protect their kidneys, we hold their home diuretics and have them be a little bit volume up on the day of the procedure, which oftentimes means that a day or 2 or 3, it's helpful to talk to them at home and see if their weight is still okay or if they need some extra doses of diuretics. We also need to monitor access sites before patients go home. We should discuss what follow-up imaging is required. After some procedure, cardiac echo before discharge or about a week or two after the procedure is helpful. Chest x-ray to make sure that the devices are still in the right place. And then also making sure that patients know what dental prophylaxis they should use. For most device implantations, we say 6 months after the procedure, and then for valve implantations, lifelong. So in conclusion, today we talked about cardiac cath in adults with congenital heart disease, the anatomic and medical complexity, the psychological considerations that we take into account when preparing for the procedure to make sure that it's successful, both from a medical point of view and also that the patient has the best patient experience they can have. It is a wonderful and rapidly evolving field, and it is very important to be prepared, knowing the history and the anatomy of the patient, discuss their expectations, and my personal favorite, the lidocaine cream. Thank you very much for having me today. Please do not hesitate to reach out to me, and have a great rest.
Thank you. We'll now move on to Sharon Gallagher. Sharon is an ACHD nurse practitioner, an important member of the Mass General Adult Congenital Heart Disease Program. Sharon has many, many years of nursing experience. I always look at people with more than 30 years of experience as starting in their teen years, so we don't age. But Sharon's experience is extensive as a visiting nurse in cardiac rehab. And Sharon has provided presentations to our Heartfelt Dreams Foundation medical education programs in the past on exercise, and we learn a great deal. And so I'm very pleased to be working with Sharon. Sharon and Lauren have been critical in making this virtual cardiac care nursing seminar come to fruition. So with that, Sharon, please, we look forward to your presentation.
Thank you for having me, and thank you for helping us put on this presentation. We're very grateful. So many of you know, yes, I'm Sharon Gallagher, and I'm the nurse practitioner on the Congenital Heart Disease program here at Mass General Hospital. And today I am going to talk about one of my passions, and that's exercise and congenital heart disease. And again, thank you to the Heartfelt Dreams Foundation for allowing us to put this together and supporting us, supporting our patients and their families, and just helping us as medical professionals in the medical community continue to learn about ACHD. So my objectives for today to talk about exercise guidelines in the general population, and then change gears and talk about exercise guidelines and what the challenges are in the ACHD population, and provide some examples of how we can implement a program in such a unique population of patients. So in terms of the benefits of exercise, it's very well established that regular physical activity is important in preventing many health problems, including diabetes, heart attacks, strokes, as well as positive outcomes for mental health. Unfortunately, only half of the adult population in the United States do actually follow the exercise recommendations. And we as providers have so many important opportunities and roles to improve on this. So in terms of the types of exercise, first and foremost, we usually target aerobic exercise, which is exercise, just as a refresher, that requires oxygen to produce energy. This type of exercise has various levels of intensity, and you can sustain it for a longer duration. Running, walking, biking, swimming are some examples. This form of exercise does improve cardiovascular conditioning or endurance, and it does so by increasing the efficiency of our respirations, increases the amount of blood pumped from the left ventricle with each contraction, and improves blood volume distribution and delivery to muscles. Other forms of exercise are anaerobic exercise. It's exercise that uses stored energy sources for energy. They're high intensity that you can't sustain for longer intervals. So HIIT classes, the high intensity interval training classes, is a good example. And you can build muscle with this form of exercise. Strength training is also important. This is also some resistance training. You can do this with resistance bands or hand weights or weight machines. We always do encourage our patients to focus on lighter weights and more repetitions because we don't like the blood pressure elevations that are could be caused by holding your breath and bearing down with higher weights. Stretching, flexibility, and balance. So this has to be one of my favorite slides. So the handle on your recliner does not qualify as an exercise machine. Each and every patient visit, each time I see a patient in the office, whether it's even 2 weeks apart, I always ask what they're doing for exercise. And one of the most common responses I get is, yes, I'm very active, or I go up and stairs frequently throughout the day. And to convey to patients that, yes, that's definitely better than sitting on the couch throughout the day, but it's still not a dedicated exercise program, and that's our goal. So in terms of what are these recommendations to the general population to start? So in 2019, the American College of Cardiology and the American Heart Association put out guidelines on the primary prevention of cardiovascular disease. So the primary prevention of the strokes and the heart attacks. And the first goal is that adults should routinely be counseled on healthcare visits to optimize a physically active lifestyle. And adults should also engage in at least 150 minutes per week of moderate intensity exercise or 75 minutes per week of vigorous intensity aerobic exercise. And we'll go through what that actually entails. And they go on to say that if adults can't meet these requirements, they'd basically be happy with any type of aerobic exercise that you could do. Resistance training is also encouraged 2 to 3 times per week. So in terms of what is considered moderate and what is considered vigorous, it's measured as a metabolic equivalent. So how many calories are burned during exercise. So moderate intensity is 3 to 5.9 METs. Brisk walking, say 2.4 to 4 miles per hour, or biking 5 to 9 miles per hour. Many patients might be able to actually monitor this because it might be a treadmill walk or a stationary bike. Recreational swimming, active yoga. The vigorous exercise is greater than 6 METs, and that's jogging, running, biking greater than 10 miles per hour. Not sure why singles tennis is preferred there, and swimming laps. And unfortunately, as we said, only 50% of adults in the United States meet these guidelines. And the other sad part to this is this has been going on since 2011. So from 2011 to 2019, still only at about 50% of the guidelines put out by the ACC and the AHA. And because this is so important, the American Heart Association has all these initiatives in the community to try to help at the school level. The NFL is also partnering with the AHA. And then other groups, the CDC, the Department of Health and Human Services, try to support this initiative as well. So knowing that, now changing gears to exercise in the congenital heart disease population, we've just learned through all the fantastic talks this morning, what is congenital heart disease? We know that it's a problem with the heart's structure that's present at birth, and it affects approximately 1 in 100 births. And we've also learned just the tip of the iceberg in terms of what could be included in congenital heart disease in terms of some maybe more simple lesions, ASD or VSD, or many of these are a combination of problems, not just one, and that these patients may have surgeries and procedures and routine testing all throughout their lifespan. And historically, congenital heart disease patients were not encouraged to participate in competitive sports. And then this recommendation carried over to recreational sports as well, just because there just wasn't any data at that time. But over time, we've learned that exercise is beneficial in this population of patients. We've also learned that patients are living longer. So in addition to the benefits from the congenital heart disease perspective, we're also trying to prevent the strokes and the heart attacks, just as we are in the general population as well. So how have we found that is a helpful measure to do this? And as Dr. DeFari talked about, the cardiopulmonary exercise test has actually proven to be very helpful on a number of levels for us. And just as the name suggests, it's a test that gives us information on the heart, the lungs, and the muscles in response to exercise. And what we've found is the CPET provides very helpful information on a patient's exercise capacity, and that's measured as a VO2 max or peak VO2. And this is the amount of oxygen that your body can consume during exercise. Gives us prognostic indicators on mortality, and it actually helps us guides treatment plans on these patients. And I also want to talk about the equation that goes into what the peak VO2 is, because it's very helpful to get a better sense of how our patients can be affected in terms of their peak VO2. So the peak VO2 is the heart rate times the stroke volume. And we also look at the arterial and the venous content in the blood. And this slide kind of breaks down the different areas of this equation that could be affected. For example, a lot of our patients we find have chronotropic incompetence on this CPET. They just can't mount the max predicted heart rate that we would want. And many of them have pacemakers in place or are on beta blockers for whether they've had arrhythmias in the past. So that could be one factor. In terms of stroke volume, they could have left-sided issues in terms of left ventricular dysfunction or elevated pulmonary capillary wedge pressures, or right-sided, where we might see a VE-VCO2 elevation, which can tell us a lot in terms of the pulmonary part of this evaluation. They may be more cyanotic or desaturate due to shunting, have RV dysfunction, or higher pulmonary vascular resistance. In terms of the arterial and the venous content, they may just have skeletal myopathies or VQ mismatch, reduced DLCO, anemia, or right to left shunting. So that's why this type of test gives us so much helpful information. So when we look at some studies that were done, this one was done in 2005, and it looked at 335 ACHD patients who underwent a CPET. And what they found is that these patients do have decreased exercise capacity. And what was also very interesting about this study is many patients weren't symptomatic. So, you know, when we're evaluating patients in the office and we ask how they're feeling, we examine them, obviously we're asking them if they're having symptoms, because a lot of times symptoms might be a driver for the next step in their treatment plan. But many of these patients were not having symptoms. Peak VO2 was found to be a reliable measure of exercise intolerance, and they found differences in peak VO2 across the ACHD spectrum, so across the range of ACHD diagnoses. Patients with a peak VO2 less than 15.5 did demonstrate an increased risk for hospital admission or death compared to patients with a peak VO2 greater than 15.5. And if we look at what those patients looked like, we can see that the patients that had the peak VO2 less than 15.5 on this chart, they said 20, they were a bit sicker. Their New York Heart Association class was more 2 to 3. They had more pulmonary artery hypertension, cyanotic. So definitely a sicker population. And this is in terms of the peak VO2 that we found across diagnoses, where we learned about aortic coarctation at the top of the chart that they had higher peak VO2s than some of the sicker ones with complex anatomy and Eisenmenger syndromes that you see at the bottom. In terms of a larger study that looked at 4,415 patients, these were patients, they were analyzed at a hospital in London as well as a PubMed search. And this study also supported, so larger number of patients, but exercise capacities does differ across ACHD spectrum. And they also saw some differences between genders. So if we were to look at what is peak VO2 in the general population, so looking at some more advanced athletes, would see, say, for example, Joan Benoit Samuelson, who won the first, I'm a runner, so I have to get the running in, the first Olympic marathon. Her peak VO2 would have been at the time in the women's chart, say greater than 49. So clearly she was off the charts. And Michael Phelps, the most decorated men's Olympic swimmer, his peak VO2 of 76 is far greater than 62, which is considered excellent on this chart. And this is what the study would look like. You could either do a treadmill test or a bicycle test, and you have a mask on to measure the oxygen exchange. You have the EKG, the EKG monitor on, blood pressure machine. So definitely a lot going on. And there's also various levels of CPET. I'm just kind of talking about the basic CPET, but there's also, you can escalate in terms of how invasive you want the test to be. A level 3 would be putting a pulmonary artery catheter in as a patient would exercise. And in terms of us kind of improving with guidelines with the ACHD population, in 2015, a task force came out in terms of exercise in the congenital heart disease population. So getting a little bit more structured in terms of how we could recommend exercise to these patients. And basically, they said that restriction from competitive athletics may well be indicated for some, but the majority of patients can and should engage in physical activity. And they went on to say that there might be other parameters that we should look at to help guide how we decide how these patients should approach exercise and determine a program. And they also talk about dynamic and static forms of exercise, because the static forms, as we talked about a little bit earlier, have a tendency to raise blood pressures more. So we're a little bit more cautious. So on the left of this chart are the increasing static components to some of the exercise options out there, and then the dynamic component going up on the right. And then in 2018, the ACC and the HCC, the 2018 guidelines, those are our most recent guidelines for congenital heart disease. They actually did put a recommendation in for exercise in sports. Again, a little bit more general, saying that clinicians should assess activity levels at regular intervals and counsel patients on the types and intensity of exercise appropriate to their clinical status. CPET can be useful to guide these recommendations, and cardiac rehab can be useful to increase exercise capacity in patients with ACHD, because some prior studies have shown that, but still a bit general. So then the European Heart Journal started, the European Heart Journal in 2013 started to look at some parameters to make it a little bit more structured, and how we could go ahead and do this. Like I said, this patient population has quite a range. And they came up with 5 parameters to look at: ventricular structure and function, pulmonary artery pressure, the aorta, is there any dilation, any arrhythmias, and oxygen saturation. And then they took it a little bit further, and in 2020 came up with specific guidelines. So the European Society of Cardiology actually went through these parameters and how we could look at this. So ventricular function could usually be by echocardiogram or cardiac MRI, which most of our patients do have. Pulmonary pressures often can be seen on echo. Sometimes patients have had heart catheterizations and a right heart cath that we can look at this as well. The size of the aorta, again, echo or cardiac MRI. Assessment of arrhythmias, they've all had 12-lead ECGs. Some of them have had Zio monitors, Holter monitors as well. And assessment of saturations. And then they came up with this really helpful diagram in terms of individualizing a program. And it's self-explanatory in the sense that the green means those patients have a little bit more less limitations to a program. Orange, a little bit more cautious, and red, definitely more cautious. And then they go into, again, talking about these, indications in terms of class 1 indication is how we assess and evaluate using these parameters. So I'd like to talk about one patient in particular in terms of using this program, in terms of, coming up with an exercise program. We have TL, who's a 33-year-old male who has a history of congenital pulmonic stenosis. And so, as we've learned before, that means that he was born with a narrowing to that pulmonic valve. And when he was 3 years old, he had open surgical valvotomy, meaning he had open heart surgery to open up that pulmonic valve. And where that's very successful in the later years, what we may see is that they have pulmonic regurgitation, so now leakiness. And the leakiness causes a decrease in the right ventricular function and may cause right ventricular enlargement. So he has been exercising aerobically 20 to 30 minutes on a treadmill several times a week. Also knows he does lift light weights and it knows to avoid heavy lifting. Has not had any symptoms at all, really follows a healthy diet. And if we look at his imaging from 2017, which I will start with and compare it to 2020, we'll see that his right ventricular dilation, he had an RVED volume of 129. And as Dr. DeFaria nicely outlined, that typically, if it's less than 120, that's where we may want to intervene because then that RV can return to normal. His right ventricular function was mildly impaired at 37%. And at the time, he had moderate pulmonic regurgitation. And so that was classified as a regurgitant fraction of 42%. On his CPET, he had a peak VO2 of 24.2, so about 65% predicted. And again, moderately reduced exercise capacity. And remember, another example of somebody who was exercising without symptoms. So at that time, we opted to continue to monitor him. And so in 2020, he had repeat studies. And his RV end diastolic volume was about the same. His right ventricular ejection fraction, fairly similar. At this point, he had severe pulmonic regurgitation. And his peak VO2, again, about the same. So aside from it being severe pulmonic regurgitation, his exercise tolerance remained moderately impaired. It didn't worsen. And this is his CPET results. And again, it goes through exercise capacity, cardiovascular performance, gives us his EKG, so in terms of arrhythmias, and gives us information on his pulmonary and pulmonary vascular performance. I'm actually going to skip this slide and go right to, if we wanted to do an individualized assessment of him to say, you want to continue to exercise, what should we do? We know that his right ventricular, he does have right ventricular dysfunction. From his other studies, we know that he has normal pulmonary artery pressures. His aorta is not dilated. He has not had any arrhythmias and no cyanosis. So if we bring down into what type of exercise, he actually could do a high intensity exercise or moderate intensity exercise. So it all depends on what type of static component he wants to that, because again, these are the higher static component could increase blood pressure. So we would want to be a little bit more cautious. So with these patients, I think it's really important, again, time consuming in clinic, but this would be our ultimate goal, is to find out how often they're exercising, which we often do, but really the time and the intensity. It's not often that I ask a patient, well, how many miles per hour are you doing on the bike, on that stationary bike? I do often ask what type of exercise, but I think if we had time to really ask more questions and really be dedicated to this, to these guidelines to help formulate a plan. So in terms of this patient, if he wanted to do kind of moderate static, high intensity, which would be at like baseball, lacrosse, based on that diagram I showed earlier, then we would actually know from his CPET that his peak heart rate was 185 beats per minute. So his training heart rate would be 75 to 90% of that. So we could sit down and tell him, your training heart rate is 138 to 166 beats per minute, and come up with a program for him. If he wanted more high static, moderate intensity, then his training heart rate would be 111 to 138 beats per minute. And this would be more like a wrestling type activity. And this is a different example of a patient who had tetralogy of Fallot. And I had included this from my talk last time I gave it, but it highlights what Dr. Defarrier also pointed out, with the many surgeries and different shunts that this patient had, he's now 52. He had the Waterston shunt at the palliation at the age of 13 months. He had a complete repair by the time he was 8, then surgical revision of his right pulmonary artery branch stenosis at 25, and then underwent a pulmonic valve replacement at the age of 38. So that's 4 surgeries. Active, walking 2 miles daily without symptoms. But if we look at some of his testing, we'll find his CPET in 2018 showed his peak VO2 was quite low at 17.4. Doesn't quite meet that less than 15.5 point that we saw on the prior study, but still pretty low. He also has known arrhythmias. He's had ventricular tachycardia on a Zio monitor in the past. His MRI did show he had an RV end diastolic volume of 131, and has known stenosis and regurgitation on his MRI. So he is somebody who did undergo a PVR based on all of that. And this was his echocardiogram too. So he did undergo, that was helpful to guide, because again, at the time, he was not symptomatic. And, we're also grateful that there's so many apps, and, you don't want to inundate and have it be overwhelming for a patient, but it's also very helpful if they really want to, feel like they're empowered to be part of this program for them, developing a program and trying to stay healthy and carrying out what you planned in the office. And there's many ways to do that with the apps and the heart rate trackers and all of that. We know that there are professional athletes who have been into the Olympics who have ACHD and who have won many Super Bowls. Not that we strive and push that with our patients, but knowing that it is possible. And again, my goal with our program is, I always ask, as we all do, every patient what they're doing for exercise. I think if, we had these CPETs that we obtained in more regular intervals, so we could see if those peak VO2s are dropping again, because many are not having symptoms. So before they may become symptomatic, maybe we can intervene early if it is appropriate. Echocardiogram, MRI, EKG, getting oxygen saturation levels. These are all important parameters we should look at to help guide our decisions and develop a tailored exercise regimen. And I remind everybody, heart's a muscle, and just like any other muscle in the body, it does want to stay fit regardless of what it's had done over the course of its lifespan. So, thank you all. Like I said, exercise is a passion, and I love working with this population of patients and the team that I work with. I'm very grateful. So thank you all for watching, and please reach out with any questions.
Well, thank you, Sharon, and thanks for the wonderful information and emphasizing the importance of exercise. A question has come in regard to exercise testing and recognizing now the importance of exercise testing for the adult congenital heart disease patient. When a patient has been living in an environment where, maybe falsely now, thinking that exercise is not appropriate because of their heart condition, and now they're coming into the hospital for exercise testing, there's a certain level of anxiety that they face with being masked and having all the monitors and equipment around them. Now, how best can we address that anxiety and educate the patient coming in that this is really an important part of their care and treatment?
That's a great question. A lot of times we plan it, so that we know, like if I saw somebody in the office and they said, oh, I just gained 30 pounds with COVID and I've done nothing, then if we were to plan for an exercise test, I'd say, okay, we would like to do this. Now is probably not the best time. So you work on, trying to improve, do some, basic walking, but nothing that's going to be overly taxing. Listen to your body. I always do say that. And then so we can plan on when this exercise will actually be, at a better point and give us more useful information, because knowing that you just gained weight during COVID and haven't done anything, probably wouldn't be the best time to do that. But yeah, we do try to go through the study in terms of what it entails, as best we can to prepare them.
Well, it sounds like that there's a lot of opportunity for us to continue to raise awareness and share that message among the congenital heart disease patients across the country.
Without a doubt. Yeah. And I think it's so exciting that, like I said, years ago, these patients, were told not to do that. And so, now we have more information, we know how helpful it is, and can now really give structure to a program for them. So.
Well, it's been terrific to see and work with patients at Heartfelt Dreams Foundation receiving proper care and treatment and seeing the outcome after their surgery or after their visits to the hospital. One patient in particular that I know of can certainly outwalk and out exercise some of us who are not congenital heart disease patients. And so it's terrific to have a program like this to benefit these patients.
Mm-hmm.
And that transitions us to Lauren McLaughlin, because Lauren is an ACHD program nurse critical to the adult congenital heart disease program at Mass General. And I think it's a very important topic that we look at in caring for patients after they get out of the hospital. And so, Lauren, we welcome you and look forward to your presentation.
Slideshow. I don't know how to do that. Sharon's just helping me for a second. I can just click it. Where's your slideshow? It's underneath here. Oh, you can't see it, so it should be under here. That bar.
I think if you go to
Okay, that's fine. No, I was going to try to do a slideshow, but we're going to plan B. So thank you all for having me, and Eric and Lori. Thank you so much for support of Heartfelt Dreams, such a wonderful organization that we use so much. The patients, I talk later about how much it helps patients emotionally and take some of the stress off of their shoulders when they have to make some of their appointments and so forth. So thank you very much. I'm very honored to share my thoughts and experiences as an outpatient nurse at the MGH ACHD program. I'm just going to share this slide of the International Society for Adult Congenital Heart Disease. They had a task force and figured out that optimizing team-based care is really the way to go with our complicated patients, and that the role of the nurse is important and in terms of guidance and education and support. The multidisciplinary team approach involves many people, more than what is listed here, but we have the ACHD trained cardiologist, and many of them have also been trained in pediatrics and adult, and specialized training in echocardiography, surgeons, cardiac interventionalists, again, probably both trained in pediatrics and adult. We also have advanced ACHD fellows that rotate with us, and they're an important part of the future. So we have a multidisciplinary meeting we have it on Mondays, and we have patients to be presented so that we can figure out what is the next best step for this patient in their care. And the fellows help with the presentations and what the question is. They meet with the radiologists ahead of time because it's very important, as we've been discussing, to look at the imaging. That will include MRIs, CAT scans, echoes compared to old ones, and the fellows are great to help coordinate that. We often will include specialists from other cardiac disciplines to help with our patient care if they're being followed, and we co-share with heart failure specialists, electrophysiologists. Many of our patients have atrial and ventricular arrhythmias, may have pacemakers, ICDs, need ablations. We work with maternal fetal medicine very closely for our pregnancy patients and develop a delivery plan. We have our wonderful nurse practitioner, Sharon, who is on top of everything. The role of the social worker is very important. And then nursing, and I actually communicate frequently with the nurses in the other cardiac sections for the EP nurses and the heart failure nurses, because we sort of co-share the patients, and we work together to get whatever needs to be done. So when I think about our patients, our goal for our patients is to help them to live a healthy, long, happy, fulfilled life. And developing a nurse-patient relationship on my end seems important to me, and I try to be accessible to the patients. They can call my direct line, they can send messages through our patient portal, and oftentimes I'm a go-between between the patient and the provider. So I do try to really develop a strong relationship with the patients and their families. When some of these messages come in, oftentimes the patients are feeling symptomatic. So the role of any ambulatory nurse is symptom triage. What types of symptoms are they feeling? Are they having shortness of breath? Is it increased from previous? Is it a new onset? How long have they had it? What are their weights? If they've been eating anything takeout, salty, that would maybe bring some of that on. Any palpitations, dizziness, syncope. So really try to tease out what's been going on and get a good picture to bring to the providers, figuring out what the next step is, if they need to come in to be seen, if it needs to be an urgent visit, and that can move on to admission to the hospital if needed. Prescriptions sounds kind of boring, but kind of important, because when the prescriptions come in and I look at them, I will look at the patient's last visit, and I'll say, gosh, they haven't been in 2 years. What's going on? And look through the plan. What was the plan? Oh, they were supposed to have an MRI, and they were supposed to come back in 6 months, and that never happened. So one thing we're very aware of with the adult congenital heart disease population is loss to follow-up. So sometimes they're feeling good, or life gets in the way. They're busy, they have kids, they have traveling jobs, and they don't always remember to circle back. And when you look through their appointment history, they may have canceled several appointments. So really important when the prescriptions come in, I kind of look through and try to get them back into care. And also can look through their previous history with other providers, and just make sure we're getting them in when they need to get in, and keeping them and their family in the loop. Education is a very big part of my role. I think Dr. Bhatt did talk about the health and wellness, education about preventing cardiovascular disease, education about their particular diagnosis, side effects of medications, how to take their medications, how to help them, if they can't afford their medications, find some ways to help support that. Sharon did an awesome job about exercise, which is so important. Education about meditation and stress management, which I'll go into a little bit more. And then helping with care coordination. Oftentimes the patients will come in and have some extensive surgery, and they need to go to cardiac rehab, or they need visiting nurse support, or they need frequent visits back to the hospital. And here's where Heartfelt Dreams has been so fantastic to help with patients that have financial limitations or minimal support at home, to help get them to the hospital for their visits, and take some of that stress off of them. We have some satellite clinics in cities that are about half hour to an hour away. And sometimes we've had patients, usually these patients are on the younger side, say in their early 20s, and we've set up a whole day to make it a one-stop day of a visit with the provider, several imagings, MRI, CPET, and then they don't show up, or they cancel. And I look back, and we've tried this 3 or 4 times, and And sometimes when I called to chat with them, they said my car broke down, or the person that was going to give me a ride couldn't give me a ride, or I don't even have money for the bus. So these are the type of patients that Heartfelt Dreams has really helped with. Another thing which to keep in mind with the medications, prescriptions, is anticoagulation. And we try very hard. We only follow patients' INRs with our anticoagulation team. Of course, we'll follow the patient, but we don't manage individual INRs. So the anticoagulation team will meet with the patient and set up, the guidelines and the expectations of the plan of how their INRs are managed and doses managed. I have, there are certain patients, and honestly, it's usually the 20, 30, and 40-year-old males that sometimes are not compliant with INR care. This is why I have gray hair. They are busy. They don't follow up with their INR testing, and then they're potentially going to be discharged from management of their care. So I have a lot of calling and messaging to try to get them back on board. And sometimes it's helpful. We can, if they've been compliant, get them a home monitor, and we just have to make sure they'll test, but then they don't send the results in. So we have to make sure that happens. And then we have patients on Xarelto and Eliquis as well. Heart healthy diet and exercise. This is so important, as we've told, and patients are usually pretty receptive to going through that. Sometimes I will sit down with the patient and go through what's your typical day of eating look like, and we'll talk about ways to sort of integrate some more healthier lifestyle choices in there and better food products. Sometimes they want to meet with a nutritionist, which is great. So that could really have a very individualized plan. Some patients are very interested and need to lose some weight. And we kind of go through like what apps are available, like MyFitnessPal or Weight Watchers. The weight, if there's really an issue and they've unsuccessful in the past, and we've often referred to the weight loss center at the hospital, and some patients have had bypass surgery, gastric bypass surgery, and have done phenomenally after that. So we really try to look at where the patient's at, where they need to be, and how can we help them to get there. Good sleep hygiene and good habits. I think a lot of people know about this, but sometimes when patients call in and they're saying, I'm so tired. And so we kind of go through, it could be related to their heart. But then when I'm chatting with them, they'll say, well, I only get about 5 to 6 hours of sleep a night. So we will go through the importance of, avoiding caffeine and alcohol, and doing that daily exercise, which is so important. And then keeping the routine, keeping those screens and televisions off an hour or so before bed, and try and have a nice, calm, restful environment, and see if that helps. Now, also for good sleep hygiene, we have patients that need CPAP. And when I talk to them, they'll say, oh, I haven't been using my CPAP machine, which this could be contributing to why they're so tired, of course. And so, we encourage them, they don't like the mask, to reach out and talk to the company and see if they can get some other examples of masks, because they're resistant to that. But when you kind of prompt them, I've had patients come back and say, that was such a great idea. I feel so much better. So try to stay on top of all those CPAP issues. So some of our patients, we get patients that are young, in their late teens on up, and at every visit, birth control should be discussed. Every patient is individual, and whatever birth control is safest for the patient, of course, is the best one. And so that really is a decision between the doctor or nurse practitioner and the patient. And sometimes we need to rope in the GYN service. But birth control is important, and I love to see that in the note that it was discussed. Sometimes patients are not in a relationship and it's not a big deal for a long time, and then the next time they come in, they're in a relationship, and it's something we need to think about. And also what medications they're on, what their long-term goals for birth control are. If they're planning to get pregnant, then we would need to maybe change some of their medications around, and they would stop their birth control. So those are other little issues that we like to talk about. Transition pediatrics to adult care. So when the patient and their family are in the pediatric care and going to those visits, they usually try to start around age 12 to start talking about transition to adult care, to sort of plant the seeds. And what we really try to work on is that the patient understands their particular diagnosis. Sometimes all they know is I had a hole in my heart. So it takes repetition over the years and when they're ready to sort of understand it. But to make sure that a successful transition, I guess, is to make sure they know what their diagnosis is. They know what medications, if they're on any, what their medications are, that they are taking them consistently. And our goal for when they come to us is that they are initiating prescription refills instead of the parent. And it's also, we need to support the families and the parents to sort of step back and promote the independence for the patient. Also, patients should be making their own appointments, either in person or virtual visit. Sometimes they make them, but they don't show up. So that's another marker that we're trying to use to see that they have successfully transitioned. We always offer, if they want to come and see our clinic first. The waiting room is different, and it's very busy, and it's not as kind of kid friendly. But by that time, patients are ready to transition, and all the ones we've offered really haven't taken us up on that. I do see some patients opting for virtual visit with a new provider, or once in a while, the provider will go down and to a visit where they're at their pediatric cardiologist and meet with them. But they've been well prepared, I think, so they're ready for the next step. And then we just want to make sure the parents and the young adult and the care team are all on the same page in terms of, can we talk to the parent if they call and give them any information? And we need the patient's permission. Sometimes patients are off to college and the mother's calling, oh, they're coming home. They asked me to help set up a visit. So little gray area, because we'd like them to make their own visits, but I think we do try to help them if they're busy and get them to do it themselves, but also, do cooperate with the patient's parents. But if the parents call in with symptoms or whatever, we do encourage them to say, you really need to talk to your son or daughter and have them reach out to us. Travel and planning. So like I said, we want everyone to have a fun, fulfilled life. And many of our patients are interested in traveling, and it's great. You just need to be prepared. So if there's going to be a big travel, it's great to talk to the provider. And the Adult Congenital Heart Association has a national clinic directory of where there are centers across the country and also internationally. So we can sort of get that set up and give them that address and information. We try to make sure that they have a sufficient supply of their medication to take with them. And sometimes it's as simple as calling the pharmacy and asking for like a travel waiver where they can get, they are in touch with the insurance company, the pharmacy, and they can get a longer supply of medication to take with them. If it's within the country, we can print out a prescription or send it electronically if they're in one particular place. If they have INR testing, we work with our AMS colleagues and try to find a lab or a hospital wherever near where they're going to be to make sure that there's consistent INR testing. And the AMS nurse and the patient should have a system through email or the patient portal where they discuss dosing and what the results are. We do encourage for long travels, maybe some compression stockings or pumping their feet to prevent some blood clots, to get up, stay well hydrated. And then copies of relevant records. So the great thing, some patients want a printout of their EKG and their records to bring with them. A lot of times, like I said, the patient can go on their phone and look up their patient portal and get that information. One recommendation, though, that I would have is to make sure that there's something in their wallet. When I worked in a cardiac ICU, we had a patient come in a coma, and he had a phone, but of course we couldn't access it. And he was not waking up, and we were trying to find a next of kin. And tucked into the very corner of his wallet was a little address label, a little Christmas address label. And I was able to find that person and say, you know, do you have a family member up here? And that was his sister. And the two sisters came up and were with him when he passed. So doesn't sound like a happy story, but I'm just trying to talk about the importance of having something in the wallet. So even the provider's card, if that's in the patient's wallet with our contact information, and maybe on the back, we encourage them to just sort of write what their diagnosis is, if they're on warfarin or DOAC, so that there is some baseline information that they can go off of. And then the last thing would be to be up to date on all their vaccinations. And then we always ask them to send us pictures if they're going someplace great. So I love my job. I love my patients. I love my team. So here's our team, and it's our admins and our program support and our wonderful providers. So reach out to any of us. We're happy to help with any questions that you may have. And I just want to thank Heartfelt Dreams once again for this great opportunity.
Thank you, Lauren. What terrific information to share about managing patients, which is such an important aspect of what we all are doing. We have come to the end of our presentations, and we wanted to open up. If you want to unmute and ask a question, Dr. DeFaria is here, as are other members of the presentation team. If you have any questions, there is one question that we wanted to put on the table, and that is in regard to what we've learned today. We've learned a lot about how congenital heart defects can be formed, how patients are treated and cared for through their lifetime. One of the questions is, when a patient is not diagnosed as an infant or a child, but receives that surprise either through a visit with their primary care physician or jogging for 8 miles and not being able to walk up the driveway when they get back home. And how do we address that issue of a congenital heart defect patient that was not diagnosed at an early age?
Well, that's a terrific question. And there are many different congenital heart defects that are not diagnosed early in childhood and may be diagnosed later in adulthood. They tend to be defects that may not produce a loud murmur on exam. Often a murmur in a child is one way that a congenital heart defect is picked up, but not all defects make noise or make murmurs on exam. For example, some atrial septal defects, the physical exam may be very quiet and kids will grow and develop very normally until finally that extra blood flow from the atrial septal defect starts to cause some symptoms or fatigue or makes their heart size bigger. And then we pick it up at that point. So some congenital valve issues that may be the single isolated problem, congenital problem, and the valve may function just fine in early life, and it's not until a little bit later that that valve starts to get blocked or leaky, and then we hear it when we listen on exam. And then at that point, that diagnosis is made in adulthood. So there's several different congenital heart conditions that may not be diagnosed until later in life, including some pretty complicated congenital heart conditions, where there's one condition where the ventricles are actually backwards and the great vessels are all, and in fact, the way things are connected, there's no murmur on exam for some patients. And that condition may not be diagnosed until later in life when they present with an arrhythmia issue or a heart block issue. So I think most importantly for patients, you know, getting routine medical care to pick up murmurs or, you know, an abnormal EKG is really important. So routine care is critically important. But also if people feel like they have symptoms that just don't make sense and aren't fully explained, talking to their doctor about that. And sometimes screening with ultrasounds can pick up some of these things that may have been harder to diagnose earlier in life.
another question that comes in regard to the CHD population, and that pertains to heredity. And now I'm a congenital heart defect patient and I have a family. Should I be concerned about children? And what should I do about that?
Gosh, that's a great question. I welcome anyone on the line to also jump in and provide some answers. I will say there is a lot that we do not know about the genetics of why congenital heart defects happen. It's an area of a lot of active investigation, and despite a lot of investment in learning about the genetics of congenital heart disease, unfortunately, genetics are extremely complicated, and it's not like one gene causes this, but we've learned that it's probably many, many different genes, some of which we may know, some of which we may not know, that contribute to abnormal development of the heart. There are some congenital heart conditions where, in fact, there is a clear understanding of the inheritability, if you will. There's some conditions associated with, for example, atrial septal defects, called Holt-Oram, where we know 50% of offspring of a parent who has that condition will have a hole in their heart or have a congenital heart condition. So there are few sort of selected conditions where we do know the proportion of offspring who could be affected. Most congenital heart parents have a slightly higher risk of having a child with a congenital heart defect, but it's actually not markedly higher than the general population. It's on the order of a few percent, anywhere from the kind of 4 to 8% range of an offspring with a congenital heart defect, which is why we often recommend fetal echocardiography, the fetal ultrasounds, for parents who have congenital heart disease. We don't often find that their offspring have congenital heart disease, but occasionally we do. The risk is slightly higher than the general population, and so the screening is recommended. And welcome others on the line thoughts about this complicated question.
I have two other questions that came in through the registration process. One is kind of a contemporary question pertaining to the COVID-19 virus and congenital heart disease patients. And are there any special considerations that patients should be interested in or paying attention to as they go through vaccination and booster shots? And how should they address their lifelong condition with a virus such as COVID-19?
This is a great question, and something we've spent so much time thinking about in the past few years. Thankfully, there has been a few publications about COVID-19 infection and congenital heart patients. One of the larger publications came from some of our colleagues in Southern California, where there was a registry created of congenital heart patients who had COVID across the country. And this was sort of before vaccination was, more widespread and prevalent. And for most congenital heart conditions, the risk of significant complication with COVID-19 is a little bit higher in people with congenital heart disease than in those without. For some congenital heart conditions where the blood oxygen level can be low, there can be heart failure associated with that congenital heart condition. The lungs may be abnormal as part of the congenital problem. The risk of severe COVID pneumonia and death is higher than somebody without that congenital heart condition. But it really is very specific to the type of congenital heart disease that one has. So if somebody has had a simpler version of congenital heart disease and had a repair that really, took care of things, their lungs are normal, their heart pump functions otherwise normal, that person is probably not at higher risk for an adverse complication from COVID-19 compared to somebody their age. Thankfully, vaccination and boosting has dramatically reduced rates of severe COVID pneumonia, need for mechanical ventilation or intubation, and death. And so we very strongly advise all of our congenital heart patients to not only be vaccinated, but also to be both boosted for optimal prevention of those severe complications from COVID-19.
Thank you. Well, I have a last question, and it's directed to Lauren and Sharon. We have participants in the seminar today who are nurses and also nursing students. And from the nursing students, wanting to go into cardiac care specialization, do you have any recommendations for how they should attack this career direction?
I mean, I was lucky to go right into it. Right, I got myself working on. I was at the Brigham actually on a cardiac step down. My passion has always been cardiovascular medicine. I've never been the quote surgical nurse. So, you know, I got great experience and then went into the coronary care unit after that. So, kind of depending where they see themselves, if, you know, if they see themselves wanting, you know, ICU level type nursing or a step down, I would, or, you know, medicine or surgery, try to see what they could do in terms of finding jobs in those areas. And if there wasn't anything available, I mean, medical surge type units in the beginning always gives you great experience, and then you can try to find, you know, a more specific area after that. But hopefully there's jobs out there, like on like a step down unit, or usually or an ICU if they offer some type of you know, new grad internship or something like that.
And also, if you're still a nursing student, maybe a nursing assistant position, and you know, kind of focus on cardiac units or cardiac surgical units or cardiac rehab or something like that to get your foot in the door. I know I worked in the same unit for over 30 years, and quite often some of the nursing students we would hire, you know, directly into the unit, into our new nurse ICU program that we had at the time. So trying to get your foot in the door, even as an assistant, would help.
Great recommendations. Well, we have another question that, as this is a virtual seminar using technology, the question goes to Dr. Tafaria on telemedicine. And for CHD patients that either have not been to the hospital, are having difficulty going to the hospital, or are just not available to go to the hospital, how has telemedicine helped in the ACHD program connect with these patients?
Mhm. Great question. And I will say we have a local true expert in this area. Dr. Bott has really pioneered the concept implementation of telemedicine in the congenital heart clinic here way before COVID-19 happened, and we were really forced to think about it. So I want to ensure she has lots of credit here for the work she's done over almost a decade in trying to facilitate virtual care. So there have been a lot of tremendous benefits of virtual consultation and visits. Having an opportunity to have a face-to-face touch point with patients and hear their symptoms, hear what's going on, and have the time and the space in our schedule to do so. As many of you probably know, medicine is just getting busier and busier and busier with more and more and more things to do for every patient encounter. It gets very hard for doctors and our nurses to sit down and have time to talk with our patients. And that's the most important thing we do in taking care of them and figuring out what's going on. It can be hard to do that on a gateway message on the fly, or, you know, EMR, electronic medical record message on the fly, or a quick phone call in between patients. Sometimes there's not enough time. The telemedicine allows for an adequate amount of time to actually talk and listen. And often we can advance care for patients if they need certain medication adjustments, if they need to facilitate visits with other specialists, if we realize, you know, a test hasn't been done that should have been scheduled, and we can use that time to figure out, you know, how we can get that schedule to move forward for them. So there's many, many benefits of having that touch point with patients to help facilitate and advance their care and move things forward faster. There certainly are downsides to telemedicine. We are, you know, practitioners who really value listening to patients in the physical exam and understanding if they have extra fluid or not enough fluid, or is that valve problem worse than it was before. And we haven't yet had a great way to do physical examination virtually, other than what we can see on one's face. It's much harder to, you know, examine patients. And there's a lot of energy and effort going into, you know, figuring out if we can somehow get, stethoscopes home to patients so they can actually put it on their chest and we can hear it virtually for those who may not be able to come in or who live very far away. So that is one limitation, but often there's far more benefits to having that additional touch point with virtual visits. There's a huge benefit in patients who live far away from ACHD centers, because I'll tell you, it's not easy to drive here to Boston on a Monday morning with the traffic. And so that transportation barrier is actually a really important barrier that sometimes limits the care that patients get with the ACHD specialists, and why we're so appreciative of all the work Heartfelt Dreams has done to help get our patients here to us. But whenever we can provide consultation virtually that doesn't necessitate a physical exam, virtual medicine, really allows us to do that and reach patients in their home, far away from where we are here in the office, but allows us to help advance their care. I guess I'll stop there.
Yeah, I'm just going to add and say that I think, just like Dr. DeFarie said, that it's great because as a program we would love to kind of expand as we can and to see help patients in other states as well. One limitation is that we have to be licensed in those states. So it was great. Well, during the pandemic, when the state of emergency was in place, we could do more visits, and I personally definitely did. And now we can't. We have to start to get licensed in those other states, which is a bit of a barrier, because I think that for them to have the opportunity to mix some virtual visits with the in-person visits would be great. Obviously both are beneficial, but that's the one limitation now is the licensure.
And I just want to say too, what a valuable use of the virtual visit or televisit is including the family. Like sometimes the wife can't come in, or the partner can't come in, or they have children, and the children can be in the background, while you're in your virtual visit. And I've done health and wellness education or meditation visits with patients over, kind of hop on to the end of one of the provider visits and do my little piece of it, and where they wouldn't really be able to come in. So it is helpful that way.
Great. Well, at this time, if there are any participants live in the seminar that would like to ask a question, please unmute and ask the question. We'll hold for a second to see if anybody has any further questions. Not see any questions. I'm going to thank all of the presenters in today's seminar. It's just terrific to have such experience and capable providers at Massachusetts General Hospital and the Heart Center to take time out of their day to participate in the seminar. Thanks very much to Lauren and Sharon for helping to coordinate this seminar. We hope to do more in the future. And as Heartfelt Dreams Foundation is very much focused on providing that transportation to patients. We have found the challenge that patients are facing getting to the specialty heart centers. And so we're very much focused on providing transportation and accommodations to the patients and families to receive the proper care and treatment for this lifelong condition. I just want to remind all participants in the seminar that Heartfelt Dreams Foundation does provide an annual academic nursing scholarship. And some of you are already familiar with that, but you can visit our Heartfelt Dreams Foundation website for the application for the scholarship for 2022. And also remind everybody in the seminar that if you want to connect with any of the presenters in today's seminar, you can visit the Massachusetts General Hospital website and go to the Adult Congenital Heart Disease Program, where you'll find great pictures and contact information for each one of our presenters. And so with that, I want to thank everybody for participating in the seminar today. I wish you a very happy Friday afternoon. For those who participated, you will be receiving an email with a survey, which is part of our continuing education unit credit process. And the recording of this seminar will be made available through the Heartfelt Dreams Foundation YouTube channel, as well as Massachusetts General Hospital and the website. And so we'll make sure that that information is communicated to participants and others so they can take advantage of the important information that was provided in today's session. So with that, thank you, everybody. Thank you, presenters. Thank you, participants, and we'll look forward to seeing you next time. Have a great Friday afternoon.
Great. Thank you so much, Eric and Lori and Heartfelt Dreams, for all of your help and support. Take care, everyone.
Thank you.